Good to be here. I've been doing this for about 10, 12 years, and I really enjoy it, and I hope you enjoy the presentation. My goal is after this morning that you will love cardiology, and you will be delighted when you see a cardiology question on your exam, because you'll be ready. Okay? Promise. That's my promise to you. Okay. We're going to start off talking about the pediatric electrocardiogram and cardiac arrhythmias. I know that causes some anxiety, but I'll show you how easy this really is. We're again going to talk about congenital heart disease. That's the bulk of the talk. And then end up with acquired heart disease and some office-based cardiology stuff you all deal with on a regular basis. Okay, the electrocardiogram and arrhythmias. Let's review. The P wave represents atrial depolarization. The QRS, ventricular depolarization. And really the QT interval in the T wave represents repolarization of the ventricles. Okay? Remember, on the electrocardiogram tracing, each big box is 0.2 seconds or 200 milliseconds. Each little box is 0.04 seconds or 40 milliseconds. No big deal. Okay. The PR interval, the interval between the beginning of the P wave and the QRS complex, largely reflects AV nodal conduction. That's the delay between the atrium and the ventricle, the impulse traversing through the AV node. The QRS interval represents the time it takes to depolarize all of the ventricular mass. And the QT interval, measured from the beginning of the QRS to the end of the T wave, represents ventricular repolarization time and should be less than 0.45 seconds or 450 milliseconds when we correct it for heart rate, and I'll show you how to do that momentarily. Okay, the 12-lead ECG. First, I'm going to talk about the leads that look at the electrical activity in this plane. Everybody look up. We're looking at this plane, okay? And first lead is lead 1, and that is a lead that is from the right arm to the left arm, and when a depolarization wave goes in that direction, lead 1 will be positive, okay? Lead 1. Lead 2 measures electrical activity from the right arm to the left leg. That's standard lead 2. And standard lead 3 measures electrical activity, that is to say, a positive deflection, when the depolarization travels from the left arm to the left leg. This is Einthoven's triangle, a way of looking at electrical activity in this plane. For your entertainment, we add 3 other leads to look at activity in this plane. Augmented lead AVR measures electrical activity basically from the center of the chest up to the right arm. So electrical activity flowing this way will be positive. AVL, augmented lead L, left arm, will be positive when electrical activity traverses from the center of the chest to the left arm. And AVF, which is straight down to the left leg. So those are the 6 leads that we look at to determine the pattern of depolarization in the frontal plane. Okay? We then add a series of chest leads across the chest. V1 to the right of the sternum, V2 to the left of the sternum, 3, 4, 5, and 6. This measures electrical activity in the anterior-posterior dimension. Okay? And what I want you to remember and underline, V1 and V2 gives you an excellent look at the right ventricle. V5 and V6 gives you an excellent view of the left ventricle. The others you can almost forget, but don't tell anybody, okay? So those are the 12 leads that we use to record a standard electrocardiogram. Don't get confused. In pediatrics, sometimes we add an extra one on the left side, V7, and a few on the right side. Don't worry about those. Okay, so how do you read an electrocardiogram? What do you do? Just be systematic about it. Be organized when you look at an electrocardiogram, and we're going to look at some together. So start with the rhythm. Look for P waves. Are there P waves before each QRS? Is it sinus rhythm or not? And just keep in mind that a P wave can be negative in AVR. That's normal. Don't get concerned about that. Okay, sinus rhythm maybe. What's the rate? You can estimate the rate as 300 divided by the number of big boxes between heartbeats. Very easy. Okay, you can get a nice estimate of the heart rate that way. And then look at those intervals we talked about, the PR interval, AV node conduction time, QRS interval, ventricular depolarization time, QT interval, repolarization time. Just remember, each little box is 0.04 seconds or 40 milliseconds. Make sure these intervals are not prolonged. Okay, the dreaded axis. Okay, let's make this real simple. We are looking at these leads in the frontal plane, 1, 2, 3, AVR, AVL, AVF, and we're trying to decide where the QRS is pointing to mostly. Okay, look up here. In a normal child and adult, the normal axis will be between 0 and 90 degrees, which means lead 1 will be positive and lead AVF will be positive. Very easy. In newborns and young infants, the axis can drift over to the right a little bit. So lead 1 will be negative because it's pointing away from 0 degrees, which is lead 1, but it'll still be positive in AVF. In a significant axis deviation, all you need to look at to determine if there's an axis deviation of significance is AVF, the foot lead, because normal activity in a child, adolescent, adult, even a newborn should be positive in AVF. If you look at AVF and it's negative, it means the axis is up here somewhere. It's either a right or left axis deviation. So a simple way to determine whether there is an axis deviation or not. Okay? Negative in AVF, axis deviation. All right? Very simple. Okay, we did the axis, we did the rate, we did the intervals. Is there any evidence of atrial hypertrophy? Well, how do we tell atrial hypertrophy? Well, right atrial enlargement or hypertrophy, P waves, very, very clear. They look like little tents, okay? Very easy to spot. Evidence of left atrial enlargement or hypertrophy, either deep, broad, negative P waves in V1, like here, or very broad M-shaped P waves in other leads. That would be a sign of left atrial enlargement. And finally, ventricular hypertrophy. Is there any evidence of ventricular hypertrophy? Well, how do you determine right ventricular hypertrophy? Remember that I told you that V1 and V2 provide an excellent look at the right ventricle. So if you see very tall, abnormally tall R waves in V1 and V2, that's a sign of right ventricular hypertrophy. It is often accompanied by a reciprocal deep S wave in V5 and V6, the left-sided leads. But tall R in V1 and V2, right ventricular hypertrophy. Keep in mind that the T wave in V1, this is important, should be negative after the first week of life. Look for that, please, and I'll show you an example of this. If it's not perfectly, beautifully negative, that's right ventricular hypertrophy. Finally, I think some of you know that newborns are right-sided animals and they tend to have tall R waves in V1 and V2. But if you ever see a QR in V1 or V2, that's right ventricular hypertrophy. So that's how we tell right ventricular hypertrophy. What about left ventricular hypertrophy? Remember that I told you V5 and V6 along the chest leads gives you a perfect look at the left ventricle. So if you see very tall, abnormally tall R waves, positive deflections in V5 and V6, that's left ventricular hypertrophy. Sometimes you'll see a tall R wave in lead AVL also as a sign of left ventricular hypertrophy. But again, V5 and V6, a perfect look at the left ventricle. Lastly, we look at the ST-T wave segments. Do they look normal or are they abnormal? You can see diffuse ST-T wave changes in the presence of electrolyte disturbances, certain myocardial diseases, and I'll show you an example of ST elevations which you can see in ischemia, but more often in pediatrics in the setting of pericarditis. So that's our systematic look at the electrocardiogram. And, after 35 years of doing this, I still do this. I start with the rhythm, the rate, the axis, etc. So it's the only way to do it. Okay, you want to try to read some together? Okay? Sure. This is confidence boosting, okay? Watch this. All right. Here's a newborn with poor pulses and poor perfusion. Okay, let's look at it. Okay, P wave before each QRS, sinus rhythm. Is there an axis deviation here? Look at AVF. What did I tell you about AVF? It should be positive in newborns, infants, children, adolescent, and adults. In this case, it's negative, meaning the QRS axis is pointing up here somewhere. Okay, in this case, it happens to be pointing more towards the left lead, AVL, so this is a left axis deviation, okay? In addition, we see very abnormally tall R waves in V1 and V2. V1 and V2 look at the right ventricle with little reciprocal negative deflections in the left side. This is right ventricular hypertrophy. This happens to be a child with hypoplastic left heart syndrome. Okay, systematic approach. How about this one? 8-month-old boy with a murmur. Okay, let's do it. We can do it now. Look for the rhythm, P before each QRS, sinus rhythm. Let's take a look at the axis. Oops, look at AVF, negative. So you know there is an axis deviation. It's either to the right or to the left. In this case, looking at the right lead, AVR, that's this one, remember, the right arm lead? It's a little more positive than AVF. This is a right axis deviation, okay? Okay, let's continue. Let's look at the P waves, looking for hypertrophy, and lo and behold, remember what I said about tall, tented, peaked P waves as a sign of right atrial enlargement? This child has definite evidence of right atrial enlargement. And now, let's look at the ventricular hypertrophy. Remember what I said about T waves after the first week of life. They should be perfectly, beautifully negative. In this case, they are not in V1. They are flat. This is a sign of right ventricular hypertrophy. Okay? Systematic analysis. Okay? Here's an 8-year-old girl, status post-heart surgery, okay? Let's look. I see a P wave before each QRS. That's good. Looking at the axis, AVF looks kind of normal. It's positive. So this axis is a little bit away from one, standard lead 1, so it's a little bit to the right, maybe 100 degrees or so. No big deal, okay? We look for atrial hypertrophy, not sure I see it. We look at ventricular forces, and oh my gosh, what do I see here? When I'm looking at my intervals, I'm seeing a widened QRS, and does everybody recognize the bunny rabbit ears in V1? Okay? This is a sign of intraventricular conduction delay, a right bundled branch block pattern. Okay? I'm trying to show you how a systematic look at the electrocardiogram will get you to the right answer. Okay, another one. You have more in your syllabus, by the way. 6-year-old boy with a harsh murmur, right upper sternal border. Well, what produces a harsh murmur at the right upper sternal border? Could be aortic stenosis. Let's look at this. I see sinus rhythm. I see a P wave before each QRS. I see a positive deflection in AVF, so there's probably not an extreme axis deviation. Looking at atrial forces, P waves are a little broad, maybe, but what strikes me here is when I look at ventricular forces, I have these enormous R waves in V5 and V6. Remember what I told you about V5 and V6? They provide an excellent look at the left ventricle, so this is left ventricular hypertrophy. Okay, 14-year-old boy with chest pain. This really could appear on the exam, okay? Sinus rhythm, there's a P wave before each QRS. The axis is perfect. There's a positive deflection in AVF and in lead 1, so it's in that normal adolescent quadrant on that pie graph that I showed you. Atrial forces, I don't see any hypertrophy. Ventricular forces, they look okay. This is V1, that's normal, and V6 and these are okay in terms of height of the deflections. But then when I continue my systematic look and start looking at ST segments, I start noticing this. ST elevations, V5 and V6, ST elevation lead 1. This is a child with pericarditis, okay? So systematic look at the electrocardiogram will get you to the right answer. You're all prepared now, okay? Moving on. Let's talk about cardiac arrhythmias, rhythm disturbances in the pediatric patient, and conduction disturbances that you might encounter. And again, a systematic look at the tracings will get you to the right place. Okay, here's a case. 8-year-old boy, previously healthy. The important stuff's in green here. His pulse is noted by the nurse to be 80, but with periods of bradycardia, followed by more rapid rates. On exam, apart from this irregular rhythm, no other abnormalities are detected. So you might get an electrocardiogram or a rhythm strip to see what this rhythm is. And it is by far most likely to be what we call sinus arrhythmia, changes in the sinus rate due to breathing. You all do it. You're doing it now. If you don't believe me, take your pulse, okay? Breathe in, your heart rate increases. Breathe out, your heart rate decreases, okay? It just happens to be much more prominent in young children and dogs. Anybody have a dog at home? Nobody has a dog at home. Nobody in this whole room has a dog at home. Well, go visit your neighbor's dog and listen to the heartbeat, okay? It is extremely irregular. It sounds like atrial fibrillation. It's sinus arrhythmia. It's the most common cause of an irregular rhythm in children. Look, sinus beat, a pause, sinus, a pause. This is all due to breathing. It's normal. It's benign. No electrolytes, no MRI, no cardiology consult, no nothing. It is, not only is it benign, it's healthy. Okay? Sinus arrhythmia, the most common cause of an irregular rhythm in children. Another case. You're called to the newborn nursery, 10-hour-old infant, everything's fine. On your exam, you notice quite a few skipped beats, extra beats. No murmurs, the baby's doing great. What do? Probably get an electrocardiogram. And this is what you're going to see. And when you're looking at rhythm disturbances, always start where it looks most normal. Don't go here and go, ooh, what's happening? Start here. PQRST, PQRST, PQRST. Oh, an early beat, therefore a premature something. I'm lucky this time, I can actually see that there's a P wave coming very early. So it's a premature something. The QRS is perfectly normal, meaning this heartbeat's coming down the normal His-Purkinje system. So this is a premature atrial contraction. Very common in children, particularly in newborns. Benign, benign, benign. No electrolytes, no MRI, no observing in the hospital for a week and a half. It's normal. Send the kid home. Okay, let's continue. A 15-year-old boy comes to the office for clearance to play football. On your exam, you detect multiple extra heartbeats, but no other abnormalities. The kid's asymptomatic, no murmurs, no symptoms. With your approach to this patient, you might get an electrocardiogram, and this is what you're going to see. Again, don't start here. It'll make you nuts, I'm telling you. Start where it looks most normal and say to yourself, PQRST, PQRST, oops, an early beat, an extra beat, a premature beat, but this beat is of a wide QRS nature, meaning this beat is originating somewhere deep down in the ventricles, okay? So this is a premature ventricular contraction, very common in childhood. If the child is asymptomatic, if all the PVCs look the same, and if they tend to go away with exercise, and you can do it in your office, you can have them run up and down the hall, and then listen again. If the premature ventricular beats tend to decrease or go away, benign. So look at all these common arrhythmias that are benign and that require no therapy, and they're very common in children. Sinus arrhythmia, the one due to breathing. I don't care about pauses and escape beats. Premature atrial contractions, very common in the neonate. You've all seen this. And premature ventricular contractions, common in older children. All benign, all requiring no therapy and little or no evaluation. Okay, sometimes we get called for consults. Sinus bradycardia, please evaluate. Okay, that means a heart rate of less than 50 in children, less than 70 in infants. If the kids are asymptomatic, probably nothing, and also very common in young athletes. So if you have a 14-year-old who plays baseball, football, runs 10 miles, and swims 2 miles every day, the heart rate's going to be 45. Get over it, okay? It's normal and it's healthy. Now, in a post-operative patient, especially somebody with symptoms, in the back of your mind, could this be sick sinus syndrome? Have I ever seen a child with hypothyroidism and sinus bradycardia? Yes, but from across the room, I could tell that this was a case of hypothyroidism. Okay, the other side, please evaluate sinus tachycardia. Fast heart rate, greater than 160 in the newborn, greater than 120 in children. Don't need a cardiologist, you need somebody to sit down and say, what's going on here? What's the underlying cause? For example, anemia, can that cause a rapid heart rate? Yeah. Fever, pain, anxiety? Yes. Hypovolemia? Yes. Have I ever seen a child with hyperthyroidism and tachycardia? Yeah. But again, from across the room, you could kind of tell that this young lady had hyperthyroidism. Okay, so we just talked about a whole bunch of extremely common rhythm issues that are encountered in pediatrics that are benign or require just a little bit of thinking to work through. Now let's talk about other rhythm disturbances, some that can be quite serious, quite severe, and life-threatening. Okay? This is a 2-month-old infant, presents with a 2-day history of poor feeding. Baby's a little mottled, breathing a little hard, the liver's below the right costal margin, so a little bit of signs of heart failure here. And here's the key. Heart rate is 280 beats per minute. Your approach to this patient. Well, I hope you get an electrocardiogram or rhythm strip. And this is what you're going to see. A narrow QRS tachycardia at a very rapid rate where P waves are hard to see. I don't really see any here. These are T waves. And if you do see them, they're sometimes upside down, the P waves, and it's rock regular. This rhythm is rock regular. And this is, of course, supraventricular tachycardia. When you listen to them, it's very characteristic. It sounds like almost like a machine gun. It's a very characteristic sound. And this is a life-threatening rhythm disturbance. Let's talk about it in a little detail. It's most common in infants 3 to 6 months of age. Most of the kids have an otherwise normal structural heart. There's no heart disease, per se, usually. Presenting signs are signs of baby heart failure, poor feeding, poor perfusion, labored breathing. Half of them will be in heart failure after 24 hours, and some will die. Okay, audience response question number 1. Before you click, I'm going to say something. Don't click. Okay. The treatment of choice for a, underlined it, very ill-appearing, hemodynamically unstable infant with supraventricular tachycardia is. All of these are legitimate treatments. Which one is the best for a baby who's about to die? So the correct choice is DC cardioversion. All the others are okay treatments of SVT, but the best one in a critically ill baby is cardioversion, okay? It works, it's fun, it saved a baby's life, okay? All right, let's talk about some of the other possible therapies in a baby who's not so critically ill. You can try a vagal maneuver to try to stop the tachycardia. And we don't do eyeball pressure or carotid massage in the little babies, but what we do is take a bag of ice, real cold water ice bag, right? And we make use of what's called the diving seal reflex. In the Arctic, when the seal jumps into the cold water, The ice water hits the face, causes a massive vagal discharge, which almost stops the heartbeat. Okay? And that's what we do to these babies. Take the baby in one arm, take the bag of ice in the other, and you say to mom, you may not want to watch this, okay? And you put the ice bag over the baby's face. How many of you have ever done this? Come on. Okay. And how long do you do it for? Until the baby stops kicking? Wrong, okay? Do about 15, 20 seconds. It feels like a long time. And you have a very good chance of stopping the tachycardia, okay? Remember, cardioversion, never wrong. Mandatory in a very ill-appearing infant, but never wrong. Adenosine's your drug of choice, okay? Never, ever, ever verapamil less than a year of age, okay? Underline that. That's important. Okay. We then will put the baby on some kind of medication to prevent the recurrence of the tachycardia, and we usually treat them for about a year. And most babies will stop the medicine. They'll never, ever have another beat of tachycardia. You know, if the kid's like 6 or 8 years of age, when they start in with the tachycardia, they have a bit of a higher risk of recurrence. What do we treat them with? So you've stopped the tachycardia, now you want to send them home on some medication. I'm going to submit to you that probably beta blockers are your best choice, propranolol, okay? Can you use digoxin? Yeah, you can. But you have to make sure that the baby doesn't have overt signs of Wolff-Parkinson-White syndrome on the electrocardiogram that you will get after you stop the tachycardia. I'll show you that. If you don't want to worry about all that, beta blockers. And between beta blockers and or digoxin, you will be able to control 85, 90% of children, babies, infants with supraventricular tachycardia. There's a host of other antiarrhythmics that we would help you with in a child who's resistant to digoxin and or beta blockers. And finally, just to let you know that for older children who are persisting with tachycardias in spite of all attempts, there are catheter techniques, radiofrequency catheter ablation techniques to cure the supraventricular tachycardia. Okay, so here's what I'm talking about when I say get an EKG after you stop the tachycardia. This is a little baby, came in SVT, we shocked him, got him out of the rhythm. Now you get a sinus rhythm EKG, okay? And I see a P wave here, a P wave here, but look, the PR interval is frighteningly short. There's a wide QRS, a slur to the QRS. Here's a delta wave. This is evidence of an overt Wolff-Parkinson-White pathway that is operative in sinus rhythm. Do not use digoxin in this patient. Dangerous, can cause ventricular fibrillation. Having said that, most young infants and babies actually do have a connection between the atrium and the ventricle, a Wolff-Parkinson-White type connection, accessory connection, if you will, but they don't show it to you in sinus rhythm. And if they don't show it to you in sinus rhythm, you can use digoxin if you want. But again, beta blocker, propranolol, perfectly good choice. This is the most common cause of SVT in a young infant. An impulse goes down the His-Purkinje system, but because there is a connection between the atrium and the ventricle, an accessory pathway, the impulse can go down into the muscle, find this pathway, go up, down, up, down, up, down, and this is the reentry pathway of most of the cases of supraventricular tachycardia in the neonate and young infant. And again, these pathways can be ablated in the cath lab with a hot radiofrequency catheter or a cold cryoablation catheter. So this is very amenable to catheter ablation. I wouldn't do it in a 1-year-old or 2-year-old because I told you that most babies you treat with medicine for a year, stop the medicine, and they're fine. But an older kid, for sure. And just very briefly, they have a very high success rate in the cath lab for treating children with recurrent supraventricular tachycardia. Okay, moving on. SVT, that's important. That for sure will be on exam. Okay, let's look at this case. A 6-year-old girl has known congenital heart disease, tricuspid atresia. She underwent the operation for tricuspid atresia, which involves a lot of atrial surgery that I'll show you later. Used to involve a lot of atrial surgery. For the past 12 hours, she's felt weak and says her heart's beating fast. On exam, you note that her heart rate is over 200 beats per minute, and she's in mild respiratory distress. No murmurs are detected, no organomegaly. What are you going to do? Probably get an electrocardiogram, and this is what you're going to see. A narrow QRS tachycardia. This is at about 180 beats per minute, 200. And notice the characteristic sawtooth pattern of atrial flutter. Atrial flutter usually arises in the right atrium, and it's usually an up-down circuit within the whole right atrium, and that's why the P waves have this up-down appearance, this sawtooth pattern. Here's an example of a close cousin to atrial flutter. That's called atrial fibrillation. Here we have normal sinus rhythm, and on the bottom we have this irregular rhythm of QRSs accompanied by this fibrillatory background of the atria. Look at this fibrillation of the atria. Atrial fibrillation, much less common than atrial flutter in the pediatric patient. And remember I mentioned atrial flutter is a right atrial rhythm. Atrial fibrillation tends to originate in the left atrium with multiple wavelets re-entering amongst themselves, starting near the pulmonary veins. Okay, atrial flutter, atrial fibrillation. When do we see this in the pediatric patient? Well, those of you who are cardiologists or neonatologists know that sometimes you can see atrial flutter in a perfectly newborn, normal newborn, or fetus. Okay? And there's something about these atria that are so jazzed up that they sometimes throw themselves into atrial flutter, and we know that if you can get them out of the atrial flutter once, either with a medication or a cardioversion, they'll never have it again. So that's a special subsection of atrial flutter in the pediatric patient. Outside of that setting, if you encounter a pediatric patient with atrial flutter or atrial fibrillation, they usually have some underlying structural heart disease, something that's causing dilatation, stretch of the atria, such as, I don't know, AV valve regurgitation, mitral regurg with left atrial enlargement, certain forms of congenital heart disease, and certainly after repair of congenital heart disease, where there's extensive atrial stitching and surgery, that's a setup for atrial flutter. Okay, what do you do about it? Treatment. Again, if somebody is really, really ill with a tachyarrhythmia, you can cardiovert them. Okay? Otherwise, the treatment of atrial flutter and fibrillation is a two-stage approach. Okay? Number one, you want to make your patient feel better, so slow conduction through the AV node. If you can slow conduction through the AV node, the ventricular rate might go from 200 to 90. Patient feels much better. And drugs that block the AV node include digoxin, but even better, beta blockers, calcium channel blockers. You then usually have to do something to control the atrial rhythm to get that back to sinus rhythm. Choices are cardioversion or certain antiarrhythmic agents that you're not responsible for, but are mostly listed here. So it's a two-stage approach. And keep in mind, even in a pediatric patient with atrial fibrillation, just like an adult patient, if you think it's been going on for more than about 2 days, we control the heart rate with the AV node conduction blockers, let them stay in atrial fibrillation while we anticoagulate them for a while to make sure there are no clots formed in the atria that will break loose when we convert them suddenly to sinus rhythm. Okay? Just be aware of that. Atrial flutter is a real headache. We've created a generation of kids with extensive atrial surgery with very refractory atrial flutters, and we have some tricks to help some of these kids, young adults. One, potential therapy, anti-tachycardia or pacing, and then again, our radio frequency catheter tricks. This is an example of anti-tachycardia pacing. This is a patient with atrial flutter. Do you see the sawtooth pattern here? She had an extensive atrial surgery as a child and now had resistant atrial flutter. And what we did was put a pacemaker in, an anti-tachycardia pacemaker into the atrium, which listens for the occurrence of atrial flutter and then delivers a series of painless shocks. You see these electrical impulses to convert the child to sinus rhythm. So that's a little trick we have. Anti-tachycardia pacing, we use it not too commonly, but if we have to, we do. You can also take your radio frequency catheter and look in the right atrium and try to see where the circuit is of the atrial flutter and try to burn it away. And you can do it, but it's only about a 75% success rate. It's not as successful as with supraventricular tachycardia. So that's atrial flutter, atrial fibrillation. Everybody okay? Moving on. Okay, here's a case. 3-year-old boy presents with fatigue, tachypnea, history of gastroenteritis. On exam, you notice a pulse of 150 to 170, a little bit of hypotension, heart tones are present but muffled, rales in both lung fields, the liver is firm, so a little bit of heart failure here. Your approach to this child with a heart rate of 150 to 170 and signs of heart failure, an electrocardiogram, rhythm strip, and this is what we saw in this case. Okay. Wide QRS tachycardia. And I want you to always begin to assume that a wide QRS tachycardia is ventricular tachycardia and treat it as such. Now, there's some people out there, or maybe cardiology folks are going, well, how do you know it's not SVT with aberrancy, blah, blah, blah. Don't do that. You're going to make a mistake, okay? Treat it as if it's ventricular tachycardia. In this case, I know it's ventricular tachycardia because in addition to the wide QRS complex, I'm looking for P waves, and I see them, and they're like all over the place. There's no rhyme or reason for them. And that's because the ventricles are tacking, right? Atria doesn't know and doesn't care, and it keeps beating, okay? So this is ventricular tachycardia, and the question for you is, what are you going to do about it? How do you approach this? In pediatrics, you got to sit down and go, okay, what's going on here? Okay? You know, in some adult hospitals, adult patients come in every day with this due to coronary artery disease and ischemia. That's not that common in pediatrics. Far more likely are any one of these entities. So you have to do a little checklist so you can treat the patient correctly. Myocarditis. Have I ever seen somebody with an inflamed myocardium present with ventricular arrhythmias? Oh, yeah. Abnormal heart muscle, cardiomyopathies. Have I seen them present with ventricular arrhythmias, ventricular tachycardia? Oh, yeah. How about ion channel diseases like long QT syndrome? We'll talk about that in a little bit. Do they present with ventricular tachycardia? Yeah. Electrolyte disturbances, ingestions, and always be alert for the postoperative patient, like a person who underwent repair of tetralogy of Fallot. They are at risk for ventricular arrhythmias as well. What are we going to do? Sometimes you don't know what the underlying cause is initially, and don't forget, cardioversion defibrillation, 1 to 2 joules, watt-seconds per kilo. And if you get an IV in, probably the drug of choice, amiodarone IV. After you stop the ventricular tachycardia, you need a consult. We need to help you to decide how to treat this child chronically. Beta blockers, procainamide, flecainide, there's a whole list of drugs you're not really responsible for. Sometimes we can take a radiofrequency catheter and burn away the ventricular tachycardia source, and sometimes we have to implant a pacemaker-type device that will listen for the occurrence of ventricular tachycardia and deliver a shock if it's detected, a life-saving internal cardioverter defibrillator. Okay, so let me show you examples of what I'm talking about here. These are just to show you that in the presence of ventricular tachycardia, you've got to do this kind of what's going on here thinking in pediatrics. 4-year-old boy, history of recurrent seizures and syncope since 8 months of age. That's the important thing here. And he had been to every neurologist. I was in Louisiana at the time. Anybody from Louisiana? Oh, cool. Okay, I like that. We, MRIs, EEGs, sleep-deprived, anti-seizure medicine, nothing worked. Finally, they took the kid to a cardiologist in Baton Rouge. And I will tell you that he said at first he didn't think this was anything other than a seizure disorder. Look here, though. There's a red flag here. Look at this. The mother had a sister who died suddenly at age 14. Big red flag, okay? This may be a cardiac issue here, okay? So anyway, my friend said, okay, come on in. We'll put an electrocardiogram lead on. Let's see what you look like. He put the leads on, started the electrical tracing. The kid fell to the ground, had a seizure. The mother's going, that's it. That's what he does 20 times a day, okay? And then he woke up. And this is what was recorded. This is a wide QRS tachycardia, right? The QRSs are wide, therefore it's a ventricular tachycardia. And notice how it spins around on its axis. It twists and turns. And this is torsade de pointes. That's what it's called, okay? And the kid woke up, and here's a question for you. The best initial treatment for acute torsades, like this kid had in the office, A, B, C, D, or E? Go for it. Anybody doing it? Oh, okay. So let's see how we're doing here. So this is a child with torsade, and you're trying to get them out of it, and the correct response, very good. IV magnesium sulfate is the best initial treatment for torsade de pointes, this special kind of ventricular tachycardia where there's this twisting, turning of the axis. Okay? Excellent. Okay, so after this kid woke up, my friend in Baton Rouge did another electrocardiogram tracing, and this is what he found. PQRS, look at the T wave, it's kind of bizarre. And the QT interval, the interval between the beginning of the QRS and the end of the T waves, prolonged. Long QT syndrome. By the way, you measure the QT interval, okay, but you have to correct the measurement for heart rate, because when your heart rate increases when you're running, your QT interval shortens. When you sleep and your heart rate decreases, the QT interval lengthens. So you have to correct the measurement for the intrinsic heart rate. And the way we do that, the way we calculate the corrected QT interval, is to take the measured QT interval and divide it by the square root of the RR interval. That's the famous Bizet correction. And your corrected QT interval should be less than 450 milliseconds, 0.450 seconds. Okay, so but this is obvious. Looking at this, this is long QT syndrome, a long QT interval, bizarre T waves. Now, you can acquire a long QT issue through certain medications, tricyclic overdoses, certain antiarrhythmic agents, electrolyte abnormalities, hypokalemia, hypocalcemia. They can all lengthen the QT interval on the electrocardiogram, but you'll probably know that your child is on some of these medications or following electrolytes because the kid's in the intensive care unit. But probably far more common is the congenital long QT syndrome. It's not rare. Okay, that's one thing I want to drive home. This is not a rare condition. We talk about two syndromes that these are kind of older terms. The Jervell-Lang-Nielsen syndrome, that's associated with deafness. It's autosomally recessively inherited, rare, very rare. What's far more common is the Romano-Ward syndrome, no deafness, dominantly inherited, and that's what our child, the case that I showed you, had, no deafness, dominant inheritance. We now know that congenital long QT syndrome is due to mutations in ion channels that govern the repolarization of the cardiac cell. These mutations cause there to be a delay in repolarization, which is reflected by a long QT interval. And whenever you have somebody with a long QT interval, they are at risk for the torsades that I just showed you. So just for your entertainment, this will not be on your exam. These are probably the three most common ion channels and chromosomes that are responsible for congenital long QT syndrome. Two of these are potassium channel abnormalities. One is a sodium channel abnormality. And there are many, many others that are known now. And fortunately, commercial genetic testing is now available. So we have people come into the clinic, mom says, hi, I have long QT syndrome. I had a defibrillator put in because I almost died. Does Johnny have it? Okay. So you do an EKG on Johnny, and if the EKG is wildly abnormal, you go, yeah, Johnny has it. But what if the EKG is questionable, which happens about 20% of the time, or even normal, 18% of the time or so? We now can do genetic testing, find the mutation in mom, look for it in the child, and then be able to tell her Johnny has it or Johnny doesn't. So gene testing. What about treatment? Now you've diagnosed long QT. How do you save a life? Beta blockers have been shown to be effective in preventing sudden death in long QT syndrome. And if I have a high-risk patient, pacing can help, but I go right to an internal cardioverter defibrillator, a device that we implant that listens for the occurrence of ventricular tachycardia or ventricular fibrillation and delivers a shock to get the patient out of that rhythm. Absolutely life-saving. And again, don't forget torsades, treat with mag sulfate, and then shock. Another lesson from this case, any patient you have with unexplained recurrent syncope or seizures, your best test to order is an electrocardiogram. That's worth underlining. Okay, we're continuing down our road of ventricular arrhythmias, and what's the lesson again? What's the underlying cause? What's going on here? I was called to the intensive care unit. This was a 2-lane, and the nurses were showing me this, bursts of a wide QRS tachycardia. Ventricular tachycardia. What's going on here? Well, you have to ask, why is this patient in the hospital? What's going on? And this happened to be a patient with renal failure, okay? And if we look at the normal sinus beats, which everybody was ignoring, P, QRS, big tented T waves, this child had hyperkalemia as a cause of ventricular arrhythmia. So again, what am I showing you here? With a ventricular tachycardia in a pediatric patient, you have to have it. There's a mental exercise here. What's going on? This one you might like. This was Louisiana also. 16-year-old kid came in the office, cowboy hat, Wrangler jeans, cowboy boots. I go, what can I do for you, buddy? He goes, I ride the rodeo. I go, okay, good for you. What can I do for you? He goes, every time I get on that bull, I pass out. I said, let me hear that again. Every time I get on the bull, pass out. So to me, this sounded like a catecholamine, sympathetically mediated something, okay? So I said, okay, cowboy, kick them boots off. Let's go on a treadmill ride, okay? So here he is, okay, and we start putting him on the treadmill. Heart rate goes higher and higher, and look what happened. Went into a wide QRS tachycardia, almost slid off the treadmill, okay? And by this, we were able to diagnose catecholaminergic polymorphic ventricular tachycardia. Don't worry about it. I'm just trying to show you how you approach these patients, okay? And because it was sympathetically induced, we put him on beta blockers, and he rode well after that, okay? Anyway, just some fun with ventricular arrhythmias, okay? Let's move on to conduction disturbances. These are easy. Don't be afraid of these. These are really easy, okay? And by the time we're done with this, you'll be great on the boards with electrocardiogram, rhythm disturbances, conduction disturbances. Okay. Again, whenever you're looking at a rhythm strip, start where it looks most normal. PQRST, PQRST. Well, there's a P wave before each QRS, but what I'm saying, and I hope you're saying, is that the PR interval, which should never be more than one big box, is prolonged. So the question is, what's this called? And what would you say about it? What would you call it on the exam? It's first-degree heart block. First-degree heart block definition, prolongation of the PR interval. Usually very asymptomatic. Okay? Let's go to the next level. Okay, here's a patient with an irregular rhythm. You get a rhythm strip. Start where it looks normal. You're doing better. I see most of the eyes starting where it looks normal, not here. P, QRST, PR prolongs, QRST, P wave dropped. Same thing here. P, QRST, PR prolonged, P wave dropped. So what is this? Okay, here's the terminology. Don't get confused. This is a second-degree heart block. What does that mean? Some of the P waves are not conducted. That's all it means. Mobitz type 1, changing PR intervals. Okay? Also known as Wenckebach. Okay? We follow these kids. They're usually very asymptomatic. By the way, Wenckebach, he discovered this. There was no electrocardiogram machine. Here's how he did it. listened to the apical pulse, that's his QRS. He looked at the A waves of the jugular venous pulse for his atrial activity, and he said, I think there's decremental conduction within the AV node followed by a blocked beat. Could you do that? Okay? All right, so pretty cool. That's before electrocardiograms. Okay, next one. Here's another level of conduction disturbance. Let's look at this one. Remember, always start where it looks most normal. PQRST, okay, that's cool. P, nothing. PQRST, P, nothing. PQRST, P, nothing. Okay, we need to give this a name. You got to choose the right diagnosis on your multiple choice question. Okay, second degree heart block. Why? Some of the P waves are not conducted. Mobitz type 2. PR intervals are not changing. Very simple, okay? These kids require careful follow-up, and some will require a pacemaker. And finally, the granddaddy of conduction disturbances, I bet you've seen this. Call to the nursery, see a newborn, doing okay. Low heart rates were noted in utero, and heart rates of 50, 55, 60 are reported to you by the nurse. Baby looks fine. Your approach to this patient, get an electrocardiogram, and what you're probably going to find is a bradycardia with complete dissociation of the P waves from the QRS. Look, here's a P wave, there's a P wave, there's another little P wave, nothing to do with the QRSs. And this is, of course, third degree or complete heart block. And when do we see this in pediatrics in the newborn period? Well, here's your audience response question number 3. Complete third degree heart block in a newborn infant is most likely caused by maternal Lyme disease, maternal diabetes, maternal ingestion, maternal lupus, maternal preeclampsia. Go for it. Oh, we're clicking away there. I can tell it's an easy one. That's good. Okay. Very good. Is that 100%? Good going, guys, okay? Connective tissue disease, okay? Maternal lupus or other connective tissue disorders, and we'll talk about why that happens in a moment. That's a confidence booster, right? That's cool. That's good. Okay, heart block in the pediatric patient. In general, acquired heart block. The two most common ways a child will acquire heart block in life. One is surgical. The surgeon's fixing a VSD and injures the conduction system. That's called surgical heart block. And then certain infectious diseases. If you're a adolescent tripsing through the woods in Lyme, Connecticut, and you come into the ER later that summer in heart block, you have Lyme disease. Sometimes endocarditis can set up an abscess by the conduction system, which can cause heart block. But the case we just did our audience response question to was congenital heart block, which is due to the transplacental passage of maternal antibodies, IgG, directed against fetal conduction tissue and the myocardium as well. And in these moms, you can measure anti-RO, anti-LA antibodies, and they have an underlying either overt or indolent collagen vascular disease, making antibodies that injures the fetal conduction system. How do we treat heart block, complete heart block? Well, pacemaker. When do we do it? For surgical heart block, meaning that child who had the conduction system injured by a surgeon, I'll give that kid 7 days. I don't care what the heart rate is. I don't care how good the kid looks. If he's still, or he or she's still in heart block, they get a pacemaker because it has a bad prognosis. The child, the infant with congenital heart block, you got some time. Okay, they probably will require a pacemaker somewhere down the road. We look for symptoms, and this may not be until 4, 5, 8, 10 years of age, okay? And we have some heart rate guidance to help us decide when a pacemaker might be necessary. So in a child without congenital heart disease, negative congenital heart disease, a normal heart, if the heart rates are 55, 50, 55 or better on average, I'm good. We'll leave them alone. But if they slip much below 55 on average, a pacemaker is indicated. In a child whose heart is not normal, plus congenital heart disease, I don't let those rates go much below 70 before we put in a prophylactic pacemaker. So that's the treatment of complete heart block. Okay? You now have been through the dreaded electrocardiogram, okay? Rhythm disturbances, conduction disturbances, and I hope that it's a little bit clearer and made easy for you, okay? Let's begin our journey through congenital heart disease. This is the meat of the matter, okay? And we'll make it as clear and hopefully entertaining as possible. Okay, first of all, what causes it? First of all, it's the most common birth defect. The incidence is about 8 in 1,000 live births, probably much more if you count spontaneous abortions. Now, if you have a history of congenital heart disease, your offspring's risk is probably about 5%. And for aortic stenosis, it may be as high as 10 or 15%. So if mom has aortic stenosis, the risk for the baby is probably in the range of 10 to 15%. And obviously, if you, your brother, your sister have congenital heart disease, you're in a different league, needless to say. Most cases, 90%, are considered the product of multifactorial inheritance. This is a real etiology. It's not a wastebasket. We're talking about the interaction of genetic factors and environmental factors causing congenital heart disease. But increasingly, we are beginning to understand the actual genetic basis for congenital heart disease. I think you're all familiar with, and we'll point out more than once this morning, the association of a deletion on chromosome 22 in the DiGeorge region and certain forms of congenital heart disease, such as truncus arteriosus. And there are other genes that have been linked to different congenital heart defects, which you don't have to worry about. But these are increasingly being understood. Okay. 5% of congenital heart disease are due to chromosomal abnormalities, numbers of chromosomes. So, for example, and this is an association you have to know, trisomy 21, Down syndrome, the endocardial cushion defect or AV canal defect, XO, 1X chromosome, Turner syndrome, associated with coarctation of the aorta. There's no easy way to remember this other than to remember it, okay? Trisomy 13 and 18 are associated with ventricular septal defects, and Cri-du-Chat syndrome the same. So these are examples of, I'm going to call them simple chromosomal abnormalities that are associated with congenital heart disease. Now remember, we talked about the DiGeorge locus, the deletion on chromosome 22. This is important. This probably deserves an underline and all that stuff, okay? And you diagnose these deletions using a FISH test, fluorescent in situ hybridization test. And here are the heart defects that are most commonly associated with the deletion on chromosome 22 in the DiGeorge locus. Truncus arteriosus, big player. Interrupted aortic arch, big player. Pulmonary atresia with a ventricular defect, and some cases of tetralogy of Fallot, even if the kids look perfectly normal. So these are the 4 heart defects that I want you to try to keep in the back of your mind, in which case you would order a FISH test looking for a deletion on chromosome 22 in the DiGeorge region, okay? Now keep in mind, many will not have a typical DiGeorge facies, hypocalcemia because of the absent parathyroids. They will not have immune problems, absent thymus, and or developmental delay. Some will, but many will not. They'll just have that deletion on chromosome 22. This is an important slide. Okay, moving on, the cause, the etiology of congenital heart disease. Some are due to single mutant genes. And we know what these genes are often, okay? So, and some of them are inherited in a dominant fashion. Noonan syndrome, okay? Characterized by pulmonic stenosis. And in the newborn period, hypertrophic cardiomyopathy is a single mutant gene. Marfan syndrome, mutation of the fibrillin gene, okay? Causes aortic root dilatation and aortic dissection. A mutation of the elastin gene is responsible for Williams syndrome. It's associated with developmental delay, elfin facies, peripheral pulmonic stenosis, and supravalvular aortic stenosis. Again, these associations, you probably do know them already, but you kind of have to have them in the back of your mind for the exam. Holt-Oram syndrome, limb abnormalities, atrial septal defect, and ventricular septal defect. So single mutant genes, dominant inheritance. And here's a couple that are autosomal recessive inherited. Ellis von Creveld, I've seen one case in my life, therefore it'll be on your board, okay? Atrial septal defect, Pompe's disease, and cardiomyopathy. Just giving you an idea what the causes of congenital heart disease are. Okay, environmental factors. These are also associations that you're going to want to have in the back of your mind and ready with the correct answer. Maternal ingestion of lithium. Recent articles reaffirming this. Diagnosis of Epstein's anomaly of the tricuspid valve. That's a downward displacement of the tricuspid valve with tricuspid insufficiency. Lithium, remember the association. Ethanol, I think you're all familiar with fetal alcohol syndrome, ASD, VSD. How much alcohol is okay during pregnancy? We're not sure? Okay, thank you. Okay. And anticonvulsants, pulmonic stenosis, aortic stenosis, tetralogy of Fallot, retinoic acid transposition. So these are environmental exposures that have been linked with specific forms of congenital heart disease. Certain infections, we don't see rubella anymore, although I wouldn't be surprised if we start seeing it again. So congenital rubella syndrome used to be associated with narrowing of the branch pulmonary arteries and patent ductus arteriosus. Exposure to Coxsackie B in the newborn can result in a myocarditis, not really a congenital heart defect, but know that association. Maternal factors, environmental factors, know these. I know you've all taken care of infants of diabetic mothers with the hypoglycemia issues, but I think you're all aware that they sometimes are born with thickened hearts, hypertrophic cardiomyopathies, that if you just leave them alone, they tend to go away over time, okay? And sometimes transposition of the great vessels. Lupus, we just talked about, right? Collagen vascular disease, congenital heart block, not a congenital heart disease, but in a way it is, okay? Phenylketonuria, VSD, ASD, and I've seen this more commonly, very complex congenital heart disease. So know those associations, those environmental factors. Okay. Now we're going to talk about some specific congenital heart defects. The first group of defects we're going to talk about are left to right shunts. So these are the ASDs, the VSDs, the PDAs, alone or in combination, okay? And what's happening in all of these defects is blood is gushing from the left side to the right side of the heart and going out into the lungs, causing increased pulmonary blood flow. And what I want you to put an asterisk or a star or whatever, symptoms, if they are going to occur in a baby with a large left to right shunt, generally appears 4, 6, 8 weeks of age, when the pulmonary resistance is low and the flow is greatest. It doesn't occur at day 1 or 2. I'll tell you later what causes heart failure symptoms at day 1 or 2. And it doesn't start causing problems at age 8, 9, or 10 years of age. I'll tell you later what causes heart failure at 8, 9, 10 years of age. And the symptoms of this overflow of the pulmonary circuit include shortness of breath, retraction, sweating, failure to thrive. Baby heart failure, okay? Not pillow orthopnea, okay? We're talking baby heart failure here. Okay, here we go. This is important. Audience response. You guys are doing really well on these. Closing a large atrial septal defect in a 4-year-old, reasonably asymptomatic child is recommended to prevent which of the following long-term horrible complications of a large left to right shunt? Heart failure, ventricular tachycardia, irreversible pulmonary hypertension, sudden cardiac death, supraventricular tachycardia. Start clicking. Let's see how we're doing here. We're getting there. Don't be bashful. Click. This is just to learn. Excellent. Okay? So, this is important. I mean, yes, you can have heart failure. Yes, you can have sudden cardiac death. Yes, you can have supraventricular tachycardia. But what we're trying to prevent is irreversible pulmonary hypertension. And we'll talk about that in a minute. Let's talk about it now. Here's the pulmonary arterioles. Look at the pulmonary arterioles, okay? After years, months, sometimes decades of high flow, what happens is you get medial hypertrophy of these little vessels first, then intimal proliferation, and then disappearance of arterioles. And this causes a very high pressure, high resistance pulmonary hypertension associated with a slow and miserable death. Okay? So there. And that's what this slide says. So if untreated, chronic increases in pulmonary flow cause this irreversible pulmonary hypertension. You might have heard it referred to as the Eisenmenger syndrome. Okay? And this is important. It can occur in decades. Patients with an ASD, they can do well until they're 40 years old, and then all of a sudden, they got this. Okay? It can occur in years. Simple VSDs can take a couple of years if they're large enough to cause this. Okay? And sometimes it can occur in months. So the children with Down syndrome and AV canal, endocardial cushion defect, we tend to operate at before 6 months of age to prevent this. Okay? Once this happens, ball game's over. Okay? Okay, let's talk about some of these common left to right shunts. You've seen these. You know what these are. Ventricular septal defect. Very common, 25% of all congenital heart disease. Usually isolated, but can occur with other defects like an ASD or a PDA or coarctation. Many close spontaneously in the newborn. I think you've all heard these little muscular, these are defects way down here in the muscular part of the septum. Harsh systolic murmur, and they go away by 2 weeks, 4 weeks, 4 months of life. And some of the other defects I'll show you a picture of in a moment are less likely to close. But these are holes between the right and left ventricle, basically. So here's your little muscular defects. These are very commonly heard in the newborn period and tend to go away. Harsh systolic regurgitant murmurs. Okay? This is a membranous ventricular septal defect in the membranous part of the septum. Why is it called that? Because if I shine a light through your heart, there's a very thin portion there called the membranous septum. And these tend to close also, but not quite as often as the muscular defects. And then there's a special kind of ventricular septal defect right underneath the aortic valve called the supracrystal defect, which over time tends to suck in the aortic valve and cause aortic insufficiency. And we tend to recommend closure of this defect. We'll talk about that in a moment. But these are the various types: muscular, membranous, perimembranous defect, right under the septal leaflet of the tricuspid valve, and the supracrystal ventricular defect. Okay, murmur may not be present in the nursery. Remember, symptoms, if the VSD is large enough, symptoms will not occur until 4 to 6 weeks of age. On exam, if you put your hand down by the left lower sternal border, you might feel a thrill, a buzz. That's almost always a ventricular septal defect. And you will hear, with your stethoscope, a harsh systolic murmur that starts right with S1. So unlike aortic stenosis or pulmonic stenosis, where you have S1, space, diamond-shaped murmur, S2, these murmurs start right with S1. You almost can't hear S1. It's like shh, shh, shh. You've all heard them. Ventricular septal defect. Okay. If there's so much blood going to the lungs because of a large ventricular septal defect, there's a lot of blood coming back to the left atrium, you might hear the blood flowing across the mitral valve as a S3 or a soft diastolic rumble. And very importantly, if there's pulmonary hypertension present, S2 becomes loud and single. That's worth underlining. If the pulmonary flow is large, here's a typical X-ray of a large left or right shunt, a big heart, and look at this vascularity. You see this increased vascularity? That's your increased pulmonary flow. So if large enough, the chest X-ray will show an enlarged heart, and the ECG can be normal if the defects are small, or may show biventricular enlargement, hypertrophy, if the defects are large. What do we do about them? How do you manage ventricular septal defects? If small, nothing, leave them alone. Okay? For symptomatic infants with a low, moderate, or large ventricular septal defect, medicines, diuretics, afterload reducing agents, some old timers still use digoxin. You hope for spontaneous closure because a lot of these can get smaller or close on their own. But if symptoms persist, if there's failure to thrive, or evidence of increasing pulmonary artery hypertension, the irreversible kind, operate. Now, what about the asymptomatic child? We will give them till about 3 to 5 years of age. But if we think they have enough blood going to the lungs to eventually cause this, we will recommend closure of that defect. And that number is generally, when we clinically think there's about twice as much blood going to the lungs as normal, we operate to prevent this. Okay? Ventricular septal defect. Patent ductus arteriosus. It's another left to right shunt. Blood gushes from the aorta to the pulmonary artery, left to right. This accounts for 10% of cases of congenital heart disease. I think you all know that it's very common in the newborn intensive care units. Up to 70% of babies, very low birth weight babies, will have a ductus if you examine them for that. And if large, it may cause respiratory distress in a premature baby or symptoms of pulmonary overcirculation, shortness of breath, and failure to thrive in an older infant. Exam is typical. The pulses are extremely easy to feel. They're bounding, okay, because the left ventricle shoots out enough blood into the aorta, knowing that some of that blood's going to leak back into the pulmonary circuit. And you hear the famous continuous machinery murmur over the pulmonary artery because blood is continually gushing into the pulmonary artery from the aorta. Okay, what do you do about it? Well, in the premature baby, in the newborn intensive care unit, the most common treatment right now is IV indomethacin. Closes the ductus 80% of the time. Be aware of a new emerging data regarding ibuprofen and even acetaminophen as a modality for treatment of the PDA in the premature infant, but indomethacin would be your best answer on an exam question. In the older infant and child, but also sometimes in the preemie, catheter closure. You put a little catheter up into the ductus, extrude a device, and close it off, and there's always surgery as an option. So that's the patent ductus arteriosus. The next very common site of left to right shunting is the atrial septal defect. 7% of congenital heart disease, usually minimally symptomatic. Atrial septal defects are really not often typically associated with symptoms and heart failure. What's happening here is blood is gushing from the left atrium to the right atrium. You don't hear that, okay? The right atrium full of blood enters the right ventricle and then is ejected out the pulmonary artery. On physical examination, because of this overload of the right ventricle, you might feel a heave right here at the left lower sternal border. That's your right ventricle, by the way. Okay, and this blood that's shooting out the pulmonary artery can produce a soft, it doesn't punch you in the face, it's a soft systolic murmur, okay? And the hallmark, worth underlying, asterisk, yellow, whatever, the hallmark of an atrial septal defect is the famous fixed splitting of the second heart sound. So look up here, A2, P2. Let's do this backward. You're facing me. A2, P2. When you take a breath in, extra blood goes back to the right side of the heart, and P2 is delayed. Blow your breath out, P2 comes back. That's normal splitting of the second heart sound. Okay? If I punch a hole in your atrial septum, you always have extra blood going to the right side of the heart, so P2 is always split from A2. Okay? And you should be able to listen to your hearts and tell me and tell yourselves that your A2 and P2 are moving normally. Okay? You have to listen for it. Okay? And it's not uncommon for us to find 18-year-olds, 24-year-olds with atrial defects undiagnosed because the murmur doesn't punch you in the face. Okay? And the hallmark is that fixed splitting of the second heart sound. Okay. This is beautiful. You're going to love this. There are three anatomical major types of atrial defects, each one surgically different and important. So look at this. The ostium secundum defect is right here. This is the most common. This is the bullet hole in the middle of the atrial septum. Okay? There is another defect way up here where the superior vena cava hits the heart. And if you remember your embryology, you remember that that's the sinus venosus portion of the embryonic heart. And the sinus venosus ASD is associated with damage to the sinus node at surgery, at least common in the older days, and dealing with pulmonary veins that are trying to get to the left atrium. So very different surgical kind of issue here. Finally, there's an atrial defect that's low down in the atrial septum. This is in the endocardial cushion, AV canal region of the heart, and this is called the ostium primum defect. And what's special about this to the surgeon is that this partial form of endocardial cushion defect can be associated with mitral insufficiency because the endocardial cushions form the lower part of the atrial septums and part of the AV valves, okay? So each of these different defects are not just intellectual issues. They are practical surgical considerations. They may sound the same when you're listening to them, but if you're operating on these patients, you have to know which defect you're dealing with. So management of the atrial defect, well, for the secundum defect, the one that's right in the middle of the atrial septum, elective surgical or catheter closure, you can close these with a catheter. Of all secundum ASDs by age 5 years, particularly if there's twice as much blood going to the lungs as normal, because you don't want this to happen, okay? And in ladies, we might even be more aggressive and close these defects at a lower rate of pulmonary flow because we don't want a hole in your atrial septum to be open during pregnancy when clots can form in the pelvic veins and the lower extremities. You want your atrial septum closed so a little clot will not go over to the left atrium and to the brain. The ostium primum defect, that low down atrial defect, part of the endocardial cushions, repair in early childhood. And we often need to put a stitch in the mitral valve, because remember I said to you there's some mitral insufficiency associated with that defect. And remember the high up atrial defect, the sinus venosus defect. This gets repaired by about 5 years of age, and when the surgeon's repairing this very high up atrial defect, he or she is very careful about not damaging the sinus node and helping the pulmonary veins find their way to the left atrium. So that's the management of the atrial septal defect. Okay. AR5, 2 congenital heart defects that are associated with left axis deviation on the ECG. I can see some of you now, you didn't teach us that yet. It's okay, all right? A, transposition and coarctation. B, truncus and pulmonary stenosis. C, tricuspid atresia, AV canal, endocardial cushion, defects. D, total anomalous pulmonary venous return, aortic stenosis. E, tetralogy of Fallot and ventricular septal defect. Start clicking. I know it's hard, but just start clicking. Nothing's going to happen. You're not going to get ejected from the course. Click phobia. Oh, very good. Okay, there's always a distribution here. And this is one of those, you can't figure this out. It's a memory thing. But this is important. The 2 forms of congenital heart disease that have left axis deviation on the EKG, so negative in AVF, positive in AVL. There's a cyanotic defect called tricuspid atresia, and any form, partial or complete, endocardial cushion AV canal defect. The conduction systems are abnormal, left axis deviation. So good guessing, and that's a good response, okay? Again, this is a memory kind of question. Okay, speaking about AV canal defect, endocardial cushion defect. Remember we talked about the partial endocardial cushion defect, AV canal, that ostium primum atrial defect low down on the atrial septum. Well, when there's complete failure or fusion of the endocardial cushions in the embryo, there is a tremendous defect in the middle of the heart, because the endocardial cushions form the lower part of the atrial septum right here, the upper posterior back part of the ventricular septum, so you have an ASD and a VSD, and then the AV valves are also formed by the endocardial cushions. So instead of a nice mitral and tricuspid valve, you have these 5 leaflets trying to behave and act like a normal mitral and tricuspid valve, and there's often AV valve insufficiency. Because of this huge hole in the heart, everybody see it? There is a huge left to right shunt. So these kids are at risk for early developmental of heart failure and this irreversible pulmonary vascular disease, okay? On exam, you'll hear a loud first sound and a loud single second sound. There's almost always pulmonary hypertension. The right ventricle will be palpable, and there may be a systolic murmur or not, depending on how much AV valve insufficiency there might be. X-ray will show a large heart, increased pulmonary blood flow. I've shown you examples of that before. The ECG will show typical biventricular hypertrophy, and here you go, folks. Left axis deviation. It's one of the 2 big heart defects that you can expect to see, left axis deviation on the electrocardiogram. We perform elective surgery at about 6 months of age, particularly in the little babies with Down syndrome. This happens really, really quickly sometimes, okay? And the surgery is beautiful, okay? Close the atrial defect, close the ventricular septal defect, 1 or 2 patches. There's different techniques. And where the artistry comes in is to take this AV valve tissue and construct a functional mitral valve out of it, and hopefully also a reasonably functional tricuspid valve. So that's the complete repair of endocardial cushion defect, highly successful, done at or before 6 months of age. Okay, special left to right shunt I have to mention, okay, and that is the anomalous left coronary artery. So what's going on here? Here's the aorta. The right coronary is coming from the aorta. That's good. But the left coronary artery is coming from the pulmonary artery. That's not good, okay? So why is this a left to right shunt? Well, because the red blood here from the aorta, the left side of the heart, if you will, enters the coronary arteries, and once the pressures, the resistance in the lungs start dropping, the blood of the myocardium gets sucked out through collaterals into this left coronary artery to the pulmonary circuit. Therefore, it's a left to right shunt, okay? And these babies, this is worth keeping in mind, this sometimes appears on exams, presents with irritability, angina, heart failure, because of a myocardial infarction at about 2 to 4 weeks of age, and ischemia. The ECG shows an infarct pattern, and these babies need urgent surgery to reimplant the left coronary into the aorta. So just keep in mind, irritability, poor feeding, heart failure, irritability, infarct pattern on EKG, anomalous left coronary artery. There's other forms of left to right shunts you don't have to worry about, various coronary fistulas and aneurysms. Don't worry about them. They're just here for your edification. Cyanotic congenital heart disease. Okay, approach to the cyanotic patient. The first thing you do, and you do it instinctively, and it's correct, is to give oxygen. That's a good thing to do. A, it might help the patient, and B, it's diagnostic, okay? And we call this, the cardiologists call this, the oxygen test. So if you have a baby with a PaO2 of 30, 40, and you give 100% oxygen, and the PaO2 goes to greater than 100, think lung disease. Get an X-ray, something's going on here, okay? If you give 100% oxygen and the PaO2 doesn't change, that's heart disease. So it's called the oxygen test. You've all done it. You all know about it. But just remember that. And when we're talking about cyanotic congenital heart disease, this slide deserves underline, yellow marker, everything. This is the famous T defects. Tetralogy of Fallot, transposition of the great arteries, tricuspid atresia and pulmonary atresia, okay, no T, I'm sorry, okay, truncus arteriosus, and total anomalous pulmonary venous return. Think of the famous T defects. Remember, for those defects that are characterized by obstruction to pulmonary flow, such as tetralogy of Fallot because of the severe pulmonic stenosis, tricuspid atresia, blood can't get to the lungs, pulmonary atresia, blood can't get to the lungs through the pulmonary artery, the chest X-ray will show greatly diminished pulmonary blood flow, like this. So remember, we just looked at left to right shunt, so you remember all the increased pulmonary flow we saw on the X-rays? If I have a cyanotic patient, and I get a chest X-ray, and I see this, I'm looking at dark lung fields. I do not see pulmonary vascularity. I'm saying to myself, obstruction to pulmonary blood flow. I'm thinking tricuspid atresia. I'm thinking pulmonary atresia. I'm thinking severe tetralogy of Fallot, maybe. And of course, what you want to do for these babies is to open the ductus to get blood flow going from the aorta through the ductus into the pulmonary artery. So IV prostaglandin E1, some minor side effects, flushing, low-grade temperature can happen sometimes, low-grade fever, and I think the most severe complication is apnea. They get really happy, they get really sleepy, and they stop breathing. So you can either slap them on the bottom of the soles of their feet or breathe for them. But a magic drug, magic opens up the ductus, and all of a sudden these babies have blood flow to the lungs, and they are greatly improved. Again, the two major players causing severe obstruction to pulmonary flow, tricuspid atresia and pulmonary atresia, let's contrast them. Very cyanotic when the PDA closes, same for tricuspid atresia. On X-ray, they look pretty much the same to me. Diminished pulmonary flow on X-ray, diminished pulmonary flow. ECG can help distinguish between them. Pulmonary atresia, the EKG shows kind of a normal QRS axis for age. But remember the last audience response question that we did, the two heart defects with left axis deviation include this one, tricuspid atresia, which will show you left ventricular hypertrophy and left axis deviation, little or no murmur, little or no murmur. So it's the EKG that you can use, obviously an echocardiogram too, that can distinguish pulmonary atresia from tricuspid atresia. Here are diagrams of these two lesions. On the left is pulmonary atresia. They often have an unusable small right ventricle, but on certain circumstances they can be used. But the pulmonary valve is blocked. So you can see how in the newborn period you've got to open the ductus to get blood flow to the lungs to stabilize them. This is an example of tricuspid atresia. Almost always an unusable right ventricle. Tricuspid valve is not there. And again, the only way blood can get to the lungs is through the ductus that you open up with prostaglandin. In the newborn period, what do? Well, you give them prostaglandin, get that ductus open, stabilize them, confirm the diagnosis by echo, sometimes in the cath lab. And then in the neonatal period, what you want to do is to establish some kind of semi-permanent source of blood flow to the lungs. And what is most commonly done is this. A shunt is created between the subclavian artery and the pulmonary artery to provide a source of blood flow that the baby can go home on. And whenever you connect a subclavian artery to a pulmonary artery, that's a form of a Blalock-Taussig shunt. Okay, I'm sure you've heard that word before. So baby stabilized in the newborn period, goes home, and then we bring the baby back, usually a couple of operations done over the first year or two of life, and this is what is now done for patients with severe obstruction to pulmonary flow, tricuspid atresia, pulmonary atresia. A series of connections are made between the venous circuit, this is the superior vena cava, it is connected to the pulmonary artery. Oh, so now you have blue blood from the upper part of the body going to the pulmonary arteries to get oxygen. usually at a second operation, and there are various ways of doing this. The blood from the inferior vena cava are routed to the pulmonary arteries as well. So now you have all the blue blood coming back to the pulmonary arteries to go out to the lungs to get oxygen. And this is called the Fontan procedure. And it's generally done in stages and generally completed by about 2 years of age or so. And if I took you to a schoolyard and I said, pick these kids out, you couldn't do it. They run, they play, there's no cyanosis. All the blue blood is being directed to the pulmonary arteries to get oxygen. And obviously with sophisticated cardiovascular testing, exercise testing, you can detect differences. But looking at them out in the schoolyard, you would be hard-pressed to pick them out. Okay. Continuing our discussion of congenital heart disease with decreased pulmonary blood flow, have to mention tetralogy of Fallot. It's common, 10% of all congenital heart disease, and it consists of, in the diagram here, I don't think that the diagram in your syllabus is correct, so pay attention to the diagram up on the screen. Tetralogy of Fallot consists of a ventricular septal defect, thick right ventricular hypertrophy, the famous overriding aorta. The aorta hangs over both the right and left ventricle, and what causes the cyanosis and the murmur is this thickening of the muscle beneath the pulmonary valve, subpulmonic stenosis. So blood can't get out the pulmonary artery and instead goes out the aorta. On physical exam, harsh systolic murmur, single S2 at the left mid-sternal border, that's your pulmonary stenosis, in a cyanotic baby. In the older days, before we repair them at an early age, we would see babies developing clubbing and squatting to help improve pulmonary flow. That's rare now because we operate within the first year of life, sometimes within the first 6 months of life. The ECG shows right ventricular hypertrophy and right axis deviation. And there's the famous boot-shaped heart that you're all waiting to see that's associated with tetralogy of Fallot. Yeah, looks like a boot. I don't know. That's tetralogy of Fallot. So the boot is due to the uplifted apex of the heart, which is an indication of right ventricular hypertrophy. And in this case, pulmonary flow looks actually quite good. Tetralogy of Fallot is usually repaired within the first year of life, about 6 months of age, and the repair consists of closing the ventricular septal defect. Take a look up here, okay? And then reaming out whatever obstruction there is, causing obstruction to pulmonary blood flow. So the muscle beneath the pulmonary valve, and sometimes the pulmonary valve itself needs to be opened up, okay? For the exam, know about the tetralogy spell. This is a sudden, acute decrease in pulmonary blood flow, usually occurs in the babies upon awakening in the morning. And in the old days, before surgery, the moms would just put them to bed and they usually woke up a little later, much better. But if you're faced with a baby who's having an acute cyanotic episode from tetralogy of Fallot, oxygen should be administered. The baby will place themselves in a knee-chest position, but if they don't, help them with that. It tends to improve pulmonary blood flow. Bicarb to correct acidosis, morphine, sometimes phenylephrine, and sometimes a beta blocker are used to break the spell. A patient with tetralogy of Fallot who presents with a tetralogy spell needs surgery pretty urgently, okay? But again, we don't see this very often now because we're operating at or before 6 months of age. Okay, those are the defects, cyanotic defects associated with diminished pulmonary flow. Now let's talk about those cyanotic heart defects associated with normal or increased pulmonary blood flow. By far, the most important and most common heart defect associated with cyanosis, but on X-ray, normal pulmonary flow, is transposition of the great arteries. It is the most common cause of intense cyanosis in the newborn period, 5% of all cases of congenital heart disease. Males are more common than females. On exam, usually no murmur, Just a loud single-second heart sound because the aorta is right under the sternum. Okay? And unless there's a VSD or something else present, no murmurs. This is the heart defect associated with the famous egg on the side chest x-ray, but don't count on that in the newborn period. It's not going to happen, okay? And the electrocardiogram associated with right ventricular hypertrophy. So what you have here are two circuits in parallel. Look at this. Blue blood, right atrium, right ventricle, going out the aorta. On the other side of the heart, you have bright red blood coming back from the lungs, left atrium, left ventricle, going back to the pulmonary artery, okay? Opening the ductus with prostaglandin can help a little bit. You can get some of the blue blood to go into the pulmonary artery to get oxygen, and some of the oxygenated blood here go out to the aorta, but it's usually not enough to help. And usually we have to do something else to get the two sides of the heart connected. And this is often in an emergency procedure performed by cardiologists. And you might have heard of the famous atrial balloon septostomy. And what we do is we take a catheter, go up to the right atrium, poke it through whatever foramen ovale we can find, and once we're on the left side of the heart, open up a balloon and then pull it hard to tear the atrial septum. This was a catheter intervention technique taught to us by Bill Rashkin, Children's Hospital of Philadelphia. Before Dr. Rashkin described this procedure, these babies all died. After Bill Rashkin did these atrial procedures in the cath lab, he then gave the baby to the surgeon and said, "Your problem now," okay? Because they lived, okay? It's an amazing, amazing procedure. Once you tear the atrial septum, blue blood can get to the side of the heart to get out to the pulmonary arteries. Red blood can get out to the aorta. It's called mixing, okay? And it's a life-saving procedure. Okay, current management of the newborn with transposition of the great arteries. At about 2 weeks of age, we'll do what the obvious is, switch the arteries, put the arteries back where they belong. So now the right ventricle is connected to the pulmonary artery and the left ventricle connected to the aorta. They tried this decades and decades and decades ago, but they couldn't do it because they didn't know what to do with the coronary arteries. But once transferring of the coronary arteries became understood, this is now the procedure of choice for correction of transposition of the great arteries. And if you think about it, after this surgery, it's a normal heart. And the follow-up has been very, very good for these babies. Okay? That's the current surgery for transposition of the great arteries. This is what we used to do. And there are thousands of adolescents, young adults who had this procedure early in life before we knew how to do the switch procedure. And what was done, they didn't know how to switch the arteries, so they switched the blood flow within the atria. Look at this. Blue blood diverted to the left ventricle to go out the pulmonary artery. Red blood coming back from the left atrium got into the right atrium, right ventricle, and out the aorta. Magic. It's almost a more interesting operation to watch. Problems associated with this, however, extensive atrial surgery, sinus node damage, sick sinus syndrome, arrhythmias, atrial flutter, and in the end, you have a right ventricle pumping out an aorta, and right ventricular dysfunction, and less than a normal life expectancy because of that is a chronic problem for which these kids need to be monitored. Okay, continuing our discussion. Cyanotic heart disease with normal or increased blood flow. Truncus arteriosus, rare, but it's going to be on your exam. I'll tell you why in a second, okay? 1%. Truncus arteriosus consists of a ventricular septal defect right here. And instead of an aorta and a pulmonary artery coming off of the heart, you have one blood vessel, where is it? Right here, often with 4 or 5 leaflets that splits into an aorta, often right-sided, and a pulmonary artery. Okay, so this is the anatomy of truncus arteriosus. Normal blood flow on the chest X-ray. And these kids tend to have mild cyanosis because even though the blue blood and the red blood mix right here, the pulmonary flow is pretty good, usually. and therefore they're not intensely cyanotic. They're actually maybe high flow to the lungs, and you might have signs of heart failure. On exam, you might hear a click as these 4 or 5 leaflets of the truncal valve open. There can be biventricular hypertrophy on the ECG. But what I want you to remember about this slide, if faced with a patient with truncus arteriosus, either in real life or on a piece of paper during your exam, fluorescent in situ hybridization, looking for the DeGeorge locus deletion on chromosome 22. These children sometimes need medical treatment for pulmonary overcirculation, digoxin, diuretics, again, digoxin sometimes, and then a surgical repair at about 6 months of age. And here is how truncus arteriosus is repaired. The pulmonary artery is chopped off the aorta, the truncal vessel, and a conduit with a little valve in it is placed between the right ventricle and the pulmonary artery. This is the so-called Rastelli operation, done with a high degree of success. These conduits do need to be changed as these babies grow bigger and bigger, and fortunately that's done with a very high degree of success and very little complications. Truncus arteriosus. Another form of cyanotic heart disease associated with normal or increased pulmonary blood flow is so-called anomalous pulmonary venous return. I'm going to do this real simple, okay? I want to keep your attention here. What's happening here is the pulmonary veins come together right behind the left atrium. See the left atrium? And instead of plugging into the left atrium, they drain somewhere else. They find other venous structures to drain to. The venous structures can include a left-sided superior vena cava. They can drain into the coronary sinus. The pulmonary veins are very smart in figuring out how to get somewhere else other than the left atrium. And sometimes in the newborn period, they will get into a hepatic vein. These are the pulmonary veins coming down below the diaphragm, getting trapped here a little bit, and entering the inferior vena cava. So pulmonary veins that don't enter the left atrium, but the blood gets back to the heart through other venous routes. So here's an example of a chest x-ray. Unobstructed pulmonary venous flow is going, and the pulmonary veins are not entering the left atrium. Instead, they're entering one of those left-sided superior vena cavas, causing this very funny snowman-shaped heart. And look at the vascularity on x-ray. It looks to be quite normal, okay? So this is one example of the pulmonary veins failing to attach to the left atrium. Minimal cyanosis, minimal symptoms. These kids do need to be repaired. But the one form of total anomalous pulmonary venous return that I want you to never forget about is this one. This is a newborn who's born, respiratory distress, chest x-ray performed, oh, ground glass appearance, this must be hyaline membrane or pneumonia or something. And what you don't think about is that this is a case of total anomalous pulmonary venous return, where the pulmonary veins come together, and again, they can't get into the left atrium, so they go down below the diaphragm, infradiaphragmatic, into the hepatic vein, into the inferior vena cava, but they get scrunched during that journey, obstructed. And therefore, this is not pneumonia, this is not hyaline membrane disease, this is pulmonary edema due to pulmonary venous hypertension. These babies need an urgent operation, and the operation, reasonably simple. Open the left atrium, and there those pulmonary veins are right there. Bring them in, okay? That's the repair of total anomalous pulmonary venous return of all types. Okay. There are a couple of complex cyanotic heart defects that you don't have to worry about, but I want to teach you something, okay? And I'm talking about double outlet right ventricle right here. There's a VSD, but both the aorta and the pulmonary artery come off the right ventricle. Don't worry about this. And here's a so-called single ventricle. There's one main ventricular chamber from which the pulmonary artery comes off, the aorta comes off a little chamber here. Don't worry about it. All I want you to know about is the following. The degree of cyanosis these patients have depends on how much pulmonary stenosis they have. The more pulmonary stenosis, the louder a murmur and the more cyanosis. And both of these heart defects are repaired at about a year of age. Okay? Cyanotic heart defects. Okay? Doing okay? Continuing. A new topic. Remember we said that symptoms of heart failure, if you will, or pulmonary overcirculation with left to right shunts that occurs when? 4, 6, 8 weeks of age? I now want to teach you what causes symptoms, heart failure, in the first week of life, okay? And these are newborns presenting with decreased perfusion, acidosis, poor pulses, gallop rhythms, heart failure. If you think of one set of heart defects, you will be right almost always, and that is obstruction to left heart flow. Underline, yellow, star, whatever, okay? And this is an x-ray of a newborn who's symptomatic shortly after birth, large heart, pulmonary edema, poor pulses, heart failure. Okay, here we go. Audience response number 6. A 2-day-old newborn presents with poor pulses, poor perfusion, acidosis. An echocardiogram reveals a very tight critical left heart obstruction, coarctation of the aorta. In addition to correcting the acidosis, palliation of this newborn is best achieved by administering which of the following? DIG, dobutamine, dopamine, prostaglandin, milrinone. Click away. We got some early clicks. There we go. A lot of clicking. Oh, excellent. Excellent. So nearly 100% of you picked the right answer, prostaglandin E1, and I'll show you in a moment how by opening the ductus, you can palliate babies with critical left heart obstruction. So prostaglandin is useful not only for children with cyanotic heart disease, but also newborns with critical left heart obstruction. Good going. Okay, so heart failure in the first week of life, always assess pulses in the upper and lower extremity. That's how you diagnose coarctation. You want to measure blood pressures? Go ahead, but I can feel it with my fingers, and so can you, okay? And here is a tight coarctation of the aorta. Always feel pulses above and below. So yes, in critical left heart obstruction, dopamine, yeah, diuretics, yeah, correct acidosis, prostaglandin. Look at this. Here's a patient with a very tight coarctation right here. And notice how if you're able to open the ductus, you have the opportunity for blood to flow from the right ventricle, pulmonary artery, through the ductus and perfuse the kidneys, the mesentery, the lower extremities, and greatly improve the condition of your patient, okay? And then the patient can undergo a safe repair of coarctation of the aorta. Here is an example of a complete interruption of the aortic arch. Don't forget FISH test for the DeGeorge locus deletion on chromosome 22 for this lesion. And I think you can see here that for perfusion of the descending aorta, the ductus has to be opened up to permit blood flow to go from the pulmonary artery to the descending aorta. So never forget prostaglandin for left heart obstruction. Okay. Here's the granddaddy of left heart obstruction, and this is a patient with hypoplastic left heart syndrome. Baby's born, looks beautiful, everybody's celebrating, and then complete cardiovascular collapse. You've all seen this, okay? And look at hypoplastic left heart here. Here's what you have. Right atrium, right ventricle, pulmonary artery. Blood goes to the lungs, okay? And some blood goes across the PDA right here to fill the aorta. While that PDA is open, they're happy, okay? But once that PDA closes, ball game's over, and there's sudden cardiovascular collapse. Poor pulses, poor perfusion. So what do you do about these? Well, when I was a fellow, there was nothing you could do for these babies, and now there are some choices. So the two operative choices now, opportunities for babies with hypoplastic left heart syndrome, one is a heart transplant. And this was first championed by a surgeon, Leonard Bailey, at Loma Linda University. Anybody from there? Okay. He started transplanting babies. There was a Time magazine cover with him, like 40 of these babies that were transplanted. So the good news is when Dr. Bailey transplanted your baby had a normal heart. The not so good news is sometimes it wasn't easy to find a donor for these babies. And the other issue is you are on anti-rejection medications with all the attendant issues associated with that. So given those two challenges, there was another surgeon at Children's Hospital of Philadelphia, Bill Norwood, who said, we need to have another option. And this is what Dr. Norwood did in a series of operations. First, he used this pulmonary artery to make an aorta. Okay. Now you have an aorta, okay, coming from a right ventricle, but hey, got an aorta, okay? He chopped the pulmonary arteries off and then did the following in two stages. One, connected the superior vena cava to the pulmonary arteries. You remember this from the Fontan operation. And then a little later, diverted the inferior vena cava blood flow to the pulmonary arteries. So now you have all the blue blood going to the lungs, coming back to this heart, right atrium, right ventricle aorta, the Norwood procedure, done in several stages. And again, if I took you to a schoolyard and said, go ahead, pick out these babies, can you find them? You wouldn't be able to. They're acyanotic, they run and they play. Do they need careful follow-up for ventricular issues and other issues? Oh, yes. Okay? But these are the treatment options for hypoplastic left heart syndrome. Okay, so again, age of presentation with symptoms and heart failure. This also deserves a little emphasis in your book. Heart failure in the first week of life, we just talked about, severe left heart obstruction. That includes coarctation, hypoplastic left heart, critical aortic stenosis. Severe aortic stenosis can cause heart failure. Left heart obstruction. Heart failure at 4, 6, 8 weeks of age, remember, left to right shunts. And then a little bit later, we're going to talk about those entities, those conditions that cause heart failure at 6, 8, 10 years of age. And if you think of acquired heart disease, that's the answer. Myocarditis, rheumatic fever, endocarditis, those kinds of conditions. Okay, we're getting there. We're getting through congenital heart disease. I'm happy for you. Valvular heart disease. Okay, let's start with the big gorilla, aortic stenosis. Pretty common. 7% of all congenital heart disease. And these valves tend to be bicuspid instead of tricuspid, can be unicuspid. There is a male predominance. And just so you know, you can have aortic valve stenosis of the valve itself. You can have thickening beneath the valve, that's subaortic stenosis. Or, as we see in Williams syndrome, stenosis above the aortic valve, supravalvar aortic stenosis. But let's talk mostly about valvar. Again, many more males than females with aortic stenosis. If it's critical enough, if it's tight enough, heart failure at birth. Open the ductus, get blood to flow from the pulmonary artery, fill the aorta, and then deal with the aortic valve. Mild aortic stenosis can be asymptomatic. May present as a heart murmur, a harsh systolic murmur at the right upper sternal border. That's where it radiates to. There may be a click, a pretty constant click as that thickened aortic valve opens up, heard right after S1 at the apex of the heart. And you might feel a thrill at the suprasternal notch region. Those are the physical findings of aortic stenosis. EKG, I would expect to see, after the newborn period, left ventricular hypertrophy. This is important. Aortic stenosis is a progressive condition, needs careful follow-up. In an older child, it may present as exertional chest pain or even syncope. That is an absolute indication for intervention or surgery. And children with aortic stenosis, if anything more than mild, should be prohibited from competitive sports. Again, there's a risk of sudden death with aortic stenosis that is more than mild in degree. So here's a possible case presentation for you that might appear on your exam. This is an 8-year-old boy with a heart murmur. He has chest pain and near syncope while playing basketball. On exam, there's a systolic ejection murmur at the right upper sternal border. Aorta, think aorta. Thrill in the suprasternal notch region, and LVH with strain on the ECG. Let's look at the ECG. 1, 2, 3, AVR, AVL, AVF. Axis is normal, AVF is normal, positive, normal axis. Look at the tall R waves in V5 and V6, and look at the strain pattern. Look at the ST segments. This is a sign of ventricular strain. You don't see a beautiful T wave. You see ST depressions, okay? This child needs to be restricted from sports immediately, referred for diagnostic testing, and needs to get that aortic valve opened. 2 choices, surgery, or in the catheterization lab, take a catheter with a balloon on it, put it across the aortic valve, inflate the balloon, and tear the aortic valve. Results are as good as surgical, okay? So this is an example of a child with aortic stenosis who needs intervention. Okay, let's contrast that a little bit with another valvular stenotic lesion, pulmonary stenosis. Pretty common heart defect as well. 10% of all cases of congenital heart disease. It may be critical, it may be so tight that the baby can't get blood to the lungs as a newborn. These babies need prostaglandin and intervention in the newborn period. Otherwise, it presents as a harsh systolic murmur at the left upper sternal border. That's where your pulmonary artery is. A thrill at the left upper sternal border, if severe. A systolic click after S1, but it varies with respiration, unlike aortic stenosis. The click comes and goes with breathing. And instead of LVH, on the EKG, you see right atrial enlargement, right ventricular hypertrophy. And here's an example of a thickened, narrowed pulmonary valve and right ventricular hypertrophy. Okay. Interestingly, pulmonary stenosis rarely progresses after 2 years of age. So if you have mild pulmonary stenosis at age 2, you're probably going to have mild pulmonary stenosis at age 22. Okay? If symptomatic, or if the RV pressure is greatly elevated, more than half of the left ventricular pressure, consider intervention. And yes, surgery is an option, but we're also very good in the cath lab taking a balloon, placing it across the pulmonary valve, and opening up that stenotic pulmonary valve. Pulmonary stenosis. Let's pause a little bit and contrast aortic stenosis and pulmonary stenosis. Aortic stenosis, where's the thrill? Systolic murmur, right upper sternal border. Where's the murmur with pulmonary stenosis? Left upper sternal border. Thrill, aortic stenosis, suprasternal notch region. Pulmonary stenosis, left upper sternal border. ECGs are very different. Aortic stenosis, left ventricular hypertrophy. ECG, right ventricular hypertrophy. There are clicks. The clicks are constant in aortic stenosis at the apex and variable in pulmonary stenosis. This is the 2 most important distinctions. Aortic stenosis is often progressive and can result in sudden death. Pulmonary stenosis, rarely progressive after 2 years of age, low risk of sudden death. Okay, this slide's a good one to mark. Okay, other valves. What can happen to other valves? How about aortic insufficiency? Do we see that in the pediatric patient? Yes. We can see congenital aortic insufficiency due to an abnormal aortic valve. Rheumatic fever can eat away at an aortic valve and cause insufficiency, as can endocarditis. Marfan syndrome, don't forget, associated with a dilated aortic root and aortic insufficiency. Physical findings in aortic insufficiency, bounding pulses, okay, very hyperkinetic left ventricle, and as that blood leaks back from the aorta into the left ventricle and diastole, you hear an early diastolic decrescendo murmur beginning with the second heart sound component, A2. Sometimes that aortic insufficiency jet is so large that it prevents the mitral valve from opening normally in diastole, and you might hear a little diastolic murmur of relative mitral stenosis, the so-called Austin-Flint murmur. Here's a diagram of a patient, 9-year-old boy with Marfan syndrome. Look at the dilated aortic root. Okay, and you can see the jet of aortic insufficiency here. And please be aware of the fact that genetic testing is now available for Marfan syndrome, because some of them don't look totally Marfanoid. Sometimes they don't, but they are at risk for aortic dilatation and aortic dissection and death. And you can now do genetic testing for the fibrillin gene, and that can be very helpful in the diagnosis of patients who the stigmata are not all that clear. What do you do about patients with aortic insufficiency? Watch for signs and symptoms of exercise intolerance. Monitor left ventricular size and function. Any of these start deteriorating, intervention is required. You can use certain drugs that unload the heart, vasodilators, sometimes calcium channel blockers, to promote forward flow from the aorta and try to mitigate the backflow into the left ventricle, ACE inhibitors, calcium channel blockers, and then there's surgery. So if you need to, if the child is symptomatic or left ventricular function is deteriorating, surgery to relieve the aortic insufficiency. Kind of a similar story with mitral insufficiency, but let's talk about it a little bit. What are the etiologies of mitral valve insufficiency in children? Congenital. Some babies are born with a cleft in the mitral valve. Again, rheumatic fever can damage the mitral valve. Endocarditis can eat away at the mitral valve. And certain patients are predisposed to having abnormal mitral valves, mitral valve prolapse, such as Marfan syndrome sometimes, and Ehlers-Danlos syndrome can be associated with mitral valve prolapse, and it can occur in isolation. Here's a picture of an echocardiogram, left ventricle, left atrium. You can see a little blast of mitral insufficiency here. Physical findings include a murmur at the apex. Again, the kind of murmur that starts right with S1. No space between S1 and the murmur. If it's severe, if there's so much blood going back to the left atrium that you can hear that blood coming back in diastole, that's a relative mitral stenosis called a Carey-Coombs murmur. If the mitral insufficiency is due to mitral valve prolapse, you may hear clicks, early to mid-systolic clicks, and murmurs that change in location and intensity with changes in position. The management is similar to aortic insufficiency. So symptoms or deterioration of left ventricular size and function mandate intervention, surgical repair of the mitral valve. Tricuspid insufficiency, do we ever encounter that in the pediatric patient? Oh yeah. So a couple of scenarios. I don't know if any of you have seen newborns with transient papillary muscle dysfunction present with tricuspid insufficiency, sometimes pretty severe, tends to get better over time. We talked about the endocardial cushion defects. The endocardial cushions form part of the atrial septum, part of the ventricular septum, the AV valves. They can present with tricuspid insufficiency. Endocarditis, again, can eat away at a tricuspid valve and cause tricuspid insufficiency. And don't forget the Epstein's anomaly of the tricuspid valve, the displacement of the tricuspid leaflets into the right ventricle with tricuspid insufficiency. And don't forget the association of Epstein's anomaly with maternal ingestion of lithium. Findings will include a blowing regurgitant murmur, soft pansystolic murmur at the right lower sternal border, an enlarged liver, jugular venous dissension if there's severe tricuspid insufficiency, and the chest X-ray and EKG will show right atrial and right ventricular enlargement. And here for your entertainment is a picture of a diagram of Epstein's anomaly of the tricuspid valve. So instead of the tricuspid valve being over here, it's displaced downward into the right ventricle, associated with severe tricuspid insufficiency. And for the neonatologists in the group and the cardiologists, it's one of the few entities that will present with a heart that looks like this in the newborn period from the massive right ventricular and right atrial enlargement. Okay. Finally, I want to mention vascular rings and vascular slings. And the cue that you look for on your exam is a case presentation of a 2-month-old infant with chronic respiratory stridor, doesn't get better with anything, and dysphagia. If you have a baby presenting with those symptoms, think of a vascular ring or a vascular sling. And one of the more common variants causing these symptoms is illustrated right here. A double aortic arch pinching both the esophagus and somewhat on the trachea. And these are diagnosed, in the old days, barium swallow, but now CT scans or even better, magnetic resonance imaging. So intervention, correcting the double aortic arch or the pulmonary sling that's passing between the trachea and the esophagus is life-saving. But again, be aware of the case presentation on the exam of a 2-month-old infant with chronic respiratory stridor and dysphagia. Image that patient, look for a vascular ring. Acquired heart disease and office-based cardiology. Okay, audience response question number 7. Intravenous gamma globulin is an effective treatment strategy to prevent cardiac sequela in which of the following acquired conditions? Rheumatic fever, endocarditis, Kawasaki, dilated cardiomyopathy, Lyme cardiomyopathy. Click away. Bingo. Nearly 100%. Correct. So, intravenous gamma globulin, very important in preventing cardiac complications of Kawasaki's disease. I'm not familiar with a role in rheumatic fever. If somebody thinks there really is one, educate me, let me know, come on up afterwards. There might be, I don't know. I don't know everything, okay? Okay, so let's talk about rheumatic fever. Start, acquired heart disease. Acute rheumatic fever is an inflammatory condition following a group A streptococcal infection. It's not a new epidemic, but rheumatic fever went away for many decades. It was there in the 40s and 50s, then went away, and then all of a sudden in 1980 started coming back again. Anybody from Salt Lake City? That's where it first started appearing, okay? And that's called the new epidemic. There are genetic predispositions to rheumatic fever after a strep infection. So there are B-cell alloantigens that predisposes an individual. 85% of patients with rheumatic fever have this. Also, HLA class II alleles also associated with a higher risk of developing rheumatic fever. So there's a genetic predisposition that's pretty clear. Interestingly, this is military data. It occurs, rheumatic fever, in 3%, sounds high, of all persons with strep pharyngitis. That sounded high to us. We researched the actual report by the military decades ago, and that was the number. 3% of patients with a strep infection contracted rheumatic fever. And rheumatic fever is the consequence of antibodies that the body makes directed against strep antigens that cross-react with human heart tissue. So there are antibodies against the protoplasm membrane of the strep that attacks the sarcolemma of the heart, M protein antibodies that attack the heart muscle, and probably the most famous are the anti-carbohydrate antibodies that attack the heart valves. And rheumatic fever is one of the few conditions where there's a pathognomonic finding on pathology, the so-called Aschoff body. The new epidemic of rheumatic fever, if you will, differs from the old 1940s epidemics. The history of a preceding sore throat is not as common. All socioeconomic groups are affected. In the older epidemics, there used to be low socioeconomic groups more affected. And we are starting to recognize that there are probably 30% or so incidents of subclinical cases. The diagnosis of rheumatic fever is still made largely by application of the famous Jones criteria. Major criteria and minor criteria, 2 major or 1 major and 2 minor, plus evidence of a strep infection allows you to make the diagnosis of rheumatic fever. And the major criteria are polyarthritis, very painful joint swelling arthritis that migrates from the ankle to the wrist to the knee. Almost can't put a bed sheet on these kids, it hurts that much. Carditis, endocarditis, myocarditis, valvulitis, pericarditis, and new guidelines that came out in 2015 encourage us to use Doppler echo to detect subclinical carditis, that is to say valve insufficiencies that we can't hear, but that are clearly present by Doppler echo. Chorea. This is another major criteria for rheumatic fever. This is a kid who starts having suddenly awkward choreiform movements. Usually it's a teacher that makes the diagnosis and says, this kid's not the same, and they can't write their name. Okay, this is chorea. Subcutaneous nodules, I'll show you pictures of those on the extensor surfaces, and a special rash called erythema marginatum. I'll show you a picture of that. The last two major criteria are very uncommon now for some reason, but those are the major criteria for rheumatic fever. Minor criteria: elevated sed rate, increased PR interval, fever, arthralgia, prior history of rheumatic fever. This plus you have to have evidence of a previous strep infection. This is from a paper outlining the various presentations of rheumatic fever. I will say that 80% of the cases I've seen have been arthritis and carditis, contrary to what this paper reported. But what I do agree with is that erythema marginatum and subcutaneous nodules are very uncommon now. They used to be common in the 1940s, and now almost never. So here's an example of rheumatic fever involvement of the aortic valve. If you were to take a slice through this nodule, you would see a Aschoff body on pathology, these giant palisading giant cells. Here's an echocardiogram showing significant, this is the left ventricle, left atrium, a blast of moderate to significant mitral insufficiency due to destruction of the mitral valve by rheumatic fever. Here you can actually see the little rheumatic nodules on the mitral valve. This is the left atrium, this is the left ventricle. And with significant mitral valve involvement, cardiomegaly, pulmonary congestion. So this is severe mitral insufficiency caused by rheumatic fever. Here's a picture of erythema marginatum. It's this serpentiginous kind of rash that appears on the trunk. I've never seen it. And if you see it, it's very evanescent. So if you ever do see it, call somebody to back you up, because nobody's going to believe you. Okay? Or get a picture after getting a consent form. Okay? Erythema marginatum. And these are subcutaneous nodules found on the extensor surfaces of the elbow. I've seen them, suboccipitally, I have seen subcutaneous nodules. These are just the major criteria, the major findings in rheumatic fever. Laboratory findings: I expect an elevated sed rate, or CRP. I said you need to look for evidence of a previous strep infection. Don't expect a positive throat culture. Quite uncommon. White count can be elevated. There may be mild hematuria. And the way we document the occurrence of a previous strep infection is by looking for anti-streptococcal antibodies, elevated ASLO titers, anti-DNase Bs, and other antibodies directed against the strep. And this is found in 95% of cases of rheumatic fever. What about treatment of rheumatic fever? For patients presenting predominantly with only arthritis, and again, this is the most painful arthritis you can imagine. Interestingly, it migrates large joints, and also interestingly, it does not deform the joints. It does not cause permanent joint damage. High-dose aspirin, 80 to 100 milligrams per kilogram per day, and within 2 hours, you're a hero. It's magic. They feel better. It's just incredible. For patients with mild carditis, that means a little bit of mitral insufficiency maybe, bed rest, aspirin, 80 to 100 anti-inflammatory doses, milligram per kilogram per day. Those with moderate carditis, meaning you're starting to see a little cardiomegaly, maybe you're hearing a little pericarditis indicating that this inflammation is going through the whole heart. Bed rest, 6 weeks. Prednisone, 1 milligram per kilogram per day, 7 to 10 days, followed by high-dose aspirin for a few weeks. And finally, patients who have severe carditis, and that's defined as a patient exhibiting signs and symptoms of heart failure, bed rest, extensive long course of prednisone, don't forget to wean, taper, and heart failure medications if necessary. Inotropes, diuretics, afterload reducing agents, sometimes digoxin. Okay? So that's the treatment of rheumatic fever. What about the kid who presents like this? Chorea. Sydenham's chorea, by the way. Okay? Haloperidol and benzodiazepines can be useful. And even though the kids present doing this, don't forget to do listen and do an echocardiogram looking for carditis, because a small number, 20% or so, will have associated involvement of the heart. Okay, so somebody has had rheumatic fever, you've treated them, they're better now. We now have to prevent another attack of rheumatic fever. And adequate prevention of recurrent strep infection lowers the attack rate to way less than 1%. And the best way to do that, this is worth underlining, monthly injection of bicillin, long-acting bicillin. Clearly the best. Every article concludes the same. Can you take oral penicillin by mouth to prevent a strep infection? Yes, but it's not as good. And finally, for the patient who's allergic to penicillin, oral sulfur drugs can prevent a strep infection, but please remember, you cannot treat a strep infection with sulfadiazine. Prognosis of rheumatic fever, good. There's unfortunately still a mortality associated with rheumatic fever, about 3%. And some of these kids persist with residual heart disease. That's the problem with rheumatic fever. Doesn't bother the joints, but it hurts the heart, okay? And the residual heart disease correlates with the severity of the carditis. So somebody who presents with massive aortic insufficiency, massive mitral insufficiency, more likely to have residual heart disease. And if they get another attack of rheumatic fever, if you forget to provide the prevention strategy, if they had bad carditis the first time, they'll have bad carditis the second time. So it's really, really important to prevent a second attack of rheumatic fever. Okay, second acquired heart problem to talk about a little bit. I think you'll hear more about this in your infectious disease lecture. Endocarditis, an infection of the heart. We talk about infection of native heart tissue, primary endocarditis, and infection of prosthetic materials. We call that a secondary endocarditis. Interestingly, pediatric patients are well represented in the hospital discharge information on endocarditis. More than 20% of hospital discharges or diagnoses of endocarditis occur in the pediatric patient. It's increasing. And why is that? More children are having prosthetic materials implanted in the heart in the course of having heart surgery, and more children are surviving heart surgery. So children are a big player in terms of the number of patients with infective endocarditis. Keep in mind that 8 to 10% of cases occur in children with no previous known heart disease. They just come in with a vegetation on a valve, and there's no known abnormality of their heart. 50% of pediatric cases occur in post-operative patients, and there are certain high-risk heart defects that are more prone to endocarditis than others. And I will list tetralogy of Fallot, ventricular septal defect, and aortic stenosis as heart defects with a high predilection for developing endocarditis somewhere down the road. What happens here with endocarditis? Well, we used to think that there's a abnormal flow within the heart, a mitral valve insufficiency or an aortic stenosis causing jet lesions on the endothelial surface of the heart, or a valve, or a piece of prosthetic material, and that attracts platelets and fibrin. That's the first thing that happens, okay? Then a bacteremia occurs for some reason, and the bacteria swim in the blood and get stuck in this fibrin platelet mesh, and that causes the vegetation, the infection, the endocarditis. But please keep in mind there are also circulating immune complexes that play a role in the pathophysiology of bacterial endocarditis. A little bit about the bacteriology in children. Staph aureus and Strep viridans are equal offenders and account for 90% of all the cases. Gram-negative, like E. coli, about 2.5%, not that common. Enterococcus, which occurs 20% of the time in adults with endocarditis, is almost unheard of in pediatrics. And we don't like the diagnosis of culture-negative endocarditis. The adults like it a little more. We expect a positive blood culture in endocarditis. Keep in mind that if you do a blood culture on a patient and it comes back with staph epi, that is not necessarily a contaminant, particularly in a child with a prosthetic valve, prosthetic heart valve, and fungi such as Candida can occur, can be an offender with endocarditis, and can be seen in immunocompromised hosts. And I've seen a number of premature babies with central lines who have had probable Candida endocarditis. How do we diagnose endocarditis? It's clinical. We expect fever, new or changing heart murmur, maybe heart failure all of a sudden for no good reason. Petechia and splenomegaly, look for it. It's there, you'll find it. Roth spots, Janeway lesions, Osler nodes. I'll show you some pictures. I've not really seen these in pediatric patient. Laboratory data, you might find the patient's anemic. Elevated white count is to be expected. There may be hematuria, which is immune-mediated. Remember I said there's an immune complex component to the pathophysiology of endocarditis. And again, 98% of the pediatric patients will have a positive blood culture. Here's some pictures. Osler nodes, painful Osler nodes. Never seen this in a pediatric patient. Janeway lesions. This I've seen, and this you should look for. Splinter hemorrhages of the nail beds and conjunctival petechiae. This you will find in a pediatric patient, and splenomegaly. Look for it. Here's a picture, a diagram of an endocarditis vegetation occurring on one of the cardiac valves, the mitral valve. And here's an echocardiogram of an aortic valve. This is a bicuspid aortic valve, and I think you can see this vegetation sitting on the aortic valve. So echocardiography can be helpful in establishing the diagnosis of infective endocarditis. How do you treat endocarditis? I think you'll get this in a little more detail in infectious disease. Antibiotics for 4 to 6 weeks based on cultures and sensitivities. Keep in mind that fungal endocarditis and aggressive Staph aureus may require early surgical intervention. Some of the complications that we see associated during the course of treatment of endocarditis and their management are outlined on this slide. Heart block can occur because of an abscess occurring within the heart near the conduction system. Pacemaker would be the treatment of choice. Heart failure can occur, and obviously all of your pharmacologic tools used to treat heart failure would be employed. Embolization, if there's recurrent major emboli, surgical intervention is required to clean out that infected valve. A myocardial abscess, I've seen these. If they persist, surgery to drain the abscess of the myocardium. And if you just can't keep those blood cultures negative, surgery to help deal with the infection. These are not favorite surgical cases of the surgeons, but sometimes they need to be done. Endocarditis still has a rather high mortality rate, overall about 5 or 10% in the pediatric patient, but beware of children with tetralogy of Fallot and pulmonary atresia who present with endocarditis. They may have as high as a 48% mortality rate. So this is a real serious condition, and there is mortality associated with it, even if you do the best job you can possibly do caring for them. Okay. Prevention of endocarditis. SBE, bacterial endocarditis prophylaxis. That's antibiotic administration prior to dental procedures is recommended in which of the following conditions? Severe aortic stenosis, unrepaired atrial septal defect, unrepaired ventricular septal defect, unrepaired tetralogy of Fallot, mitral valve prolapse, commence clicking. Okay, interesting. I think vast majority of you got it absolutely correct. The only heart lesion here that in the modern era would require antibiotics before dental work is unrepaired tetralogy of Fallot or any unrepaired cyanotic heart defect. All these other defects, when I was sitting, when you're sitting, would get endocarditis prophylaxis, antibiotics before going to the dentist, no longer recommended. Okay? So they're not so new anymore, but the guidelines by the American Heart Association about who gets endocarditis prevention, dental procedures or procedures on infected skin only for children with prosthetic heart valves, previous history of endocarditis, and unrepaired cyanotic heart disease is the bottom line. Also, some cardiac transplant recipients with cardiac valvulopathy. Nobody else, not aortic stenosis, not VSDs, not PDAs, not pulmonary stenosis. Nobody else is currently recommended for endocarditis prophylaxis prior to dental work. So SBE prophylaxis is limited to only the conditions on the previous slide. And antibiotic prophylaxis for procedures on respiratory tract or infected skin only for conditions on previous slide. No antibiotic prophylaxis for GI or GU procedures. For you, this is not new, okay? But for those who were in practice for a couple of decades, this was a total change in philosophy about preventing endocarditis after dental manipulations, respiratory tract manipulations. Okay, ever see a kid like this? Everybody, right? Okay, so let's talk briefly about Kawasaki disease. It's an acquired heart disease after all. And we make the diagnosis after 5 days of fever plus 4 of these 5 features: cervical lymphadenopathy, non-exudative conjunctival injection, non-vesicular rash, edema of the hands and feet, mucosal involvement, Kawasaki's disease. Laboratory findings include an elevated white count, anemia, elevated SED rate, sterile pyuria. Often we see elevated liver function panels, decreased serum albumin, and in the intermediate stage and late stages, thrombocytosis, peeling, and the strawberry kind of tongue characteristic of Kawasaki's disease. So what's the heart issue here? Coronary artery aneurysms are the big player, and these are the dreaded consequence of Kawasaki's disease. We can diagnose these by echo, or if we have to, angiography. And in the days before we knew how to treat or prevent the occurrence of these coronary artery aneurysms, we used to see these in 20% of untreated patients. More commonly in young boys, and those young boys with the highest fevers and the elevated SED rates. Proximal left and right coronary artery aneurysms are the most common type. They can be seen usually nicely by echo. More than 50% quote-unquote resolve after 2 years, all by their own, whether these are truly actually still normal coronary arteries once they appear to get better by echo, not entirely clear. And it's the huge, giant aneurysms, those that are more than 8 millimeters in diameter, that are more likely to cause a myocardial infarction and death. So this is the cardiac complication of Kawasaki's disease. In addition to coronary aneurysms, there are other cardiac sequelae of Kawasaki's disease. You can have pericarditis 25% of the time. Just like you get aneurysms of the coronary arteries, you can get them of the subclavian artery, intercostal artery, renal artery. So when I see a patient post-Kawasaki's disease, I always look for abnormal peripheral pulsations, let's say. Okay. Myocarditis can occur in association with Kawasaki's disease. Heart failure is rare, though. EKG changes, such as STT wave segment changes, can occur, and mild dilatation of the left ventricle, left atrium with dysfunction is actually quite common. So there's myocardial involvement as well. Mitral insufficiency, not so much. Thanks to the recent treatment with intravenous immunoglobulin, mortality with Kawasaki's disease has dropped to really almost nothing, less than 0.3%. When I was an attending in the 1970s, mortality was as high as 2%, so not trivial. The causes of death, by far most common, was a myocardial infarction due to those dilated aneurysmal coronary arteries, which often develop thromboses. Heart failure can occur. And remember, I mentioned these peripheral aneurysms. They can, on rare occasion, break and be a cause of mortality. So the treatment, the way we prevent aneurysms in today's world, is intravenous immunoglobulin, 2 grams per kilo over 10 hours or so. May retreat once if there's fever that recurs 36 hours later. And if the child still remains febrile and symptomatic, people are now using methylprednisolone as a next course of therapy. And just be aware of the fact that there are investigational studies looking at the use of anti-TNF-alpha agents in the treatment of Kawasaki's disease, but not yet something that we would jump to or recommend immediately. In addition to the immunoglobulin, we begin high-dose aspirin therapy, 80 to 100 milligrams per kilogram per day for anti-inflammatory effect. And we use this high-dose aspirin until the fever and the SED rates start to come down. When we start entering the subacute phase, platelets will start to rise tremendously. And once platelets rise tremendously, you have to reduce the dose of aspirin to a low dose, 5 to 10 milligrams per kilogram per day, for its antiplatelet effect. You will not get adequate antiplatelet effect if you keep the aspirin dose at 80 to 100 milligrams per kilogram per day. Treatment of Kawasaki's disease. Okay, acquired heart disease, case presentation. 16-year-old girl presents with 1 week of increasing shortness of breath and fatigue. Past medical history benign. Usual viral illnesses as a kid, including gastroenteritis 2 weeks ago. On exam, pulse 120, respiratory rate 50, a little rapid, a little febrile, S1, S2, S3, S4, heart failure, roused bilaterally, enlarged liver. Again, heart failure in the first week of life, left heart obstruction, heart failure at about 4, 6, 8 weeks of age, left to right shunts, heart failure in an older child. Remember, something acquired. So this kid has acquired something. And this is a case presentation of a child with viral myocarditis, heart failure preceded by a viral illness, gastroenteritis. And on chest x-ray, an enlarged heart, some perihilar fluffing here. And if we were to do a biopsy, and we don't always do it in these cases, you would see heart muscle, of course, and this lymphocytic infiltration of the myocardium. So this is viral, lymphocytic, viral myocarditis, an acquired cause of heart failure in an older child. These kids may present with heart failure or arrhythmias. Here's a normal left ventricle, and here's a big dilated, poorly functioning ventricle with myocarditis. The etiology of viral myocarditis can include Coxsackie-B, echovirus, but a whole list of other possible agents. The diagnosis is clinical, and echocardiography is helpful, as I showed you here. Measurement of cardiac enzymes like troponin can give you a clue about destruction of myocardial cells and is often elevated in myocarditis. Cardiac MRI can be used to look for areas of inflammation. And again, we don't biopsy too often because we don't need to. It's a clinical diagnosis. And the problem with biopsying is you may miss areas of inflammation and come back and say, this is a normal heart. Okay, so we tend not to biopsy cases of myocarditis. The differential diagnosis, when you see a heart like this, dilated and not functioning well, active myocarditis or something else, a so-called dilated cardiomyopathy, and we'll talk a little bit about what the etiology of a dilated heart that's not functioning well outside of viral myocarditis. Acute treatment of viral myocarditis, inotropic support if necessary, dopamine, dobutamine, milrinone, diuretics, of course, afterload reduction, sodium nitroprusside, milrinone, and intravenous immunoglobulin maybe. Okay, there are some pediatric reports of some improved outcomes in patients, pediatric patients treated with IVIG. Early reports suggested better left ventricular function after the episode was over. Adult cardiologists don't do this and don't believe in this. Okay, it's a pediatric thing, just so you know. Prognosis of viral myocarditis, 70% improve. 70% get better. Interestingly, there's something called fulminant myocarditis, which is horrible in the beginning, but it actually has a little better prognosis for some reason. 70% improve, but 30% go on to develop chronic, dilated, burned out cardiomyopathy and chronic heart failure. So a substantial number of kids with viral myocarditis go on to have a bad outcome. Chronic heart failure, viral myocarditis, and even those other entities that I mentioned that we'll talk about in a second that present with a dilated heart, how do we treat them chronically? Inotropic support, maybe digoxin, maybe. Diuretics, afterload reduction, ACE inhibitors, enalapril, carvedilol, which is an alpha and beta blocker, really helps to put the heart at rest a little bit and open up the peripheral vasculature. Beta blockers are used at times because they block the harmful effects of elevated sympathetic activity on the heart. And of course, somebody who is just not stable, not progressing well, not doing well on medical therapy with chronic heart failure, cardiac transplantation is an option. Okay, viral myocarditis can present with a dilated heart that is poorly functioning. But what about those other cases that present with a dilated heart that aren't due to active viral lymphocytic myocarditis? Well, they could be a burned out sequela of a viral myocarditis. There are other entities such as endocardial fibroelastosis, don't worry about that, that can present with a dilated heart. And finally, there are also genetic causes of a dilated, poorly functioning heart. These are X-linked, autosomal dominant, autosomal recessive. These are defects of the proteins, tends to be, that link the contractile proteins of the heart to the sarcolemma, the other matrix parts of the cardiac cell. So the one you know probably very familiar with is dystrophin in muscular dystrophy. There's a mutation of that protein which presents with a dilated, poorly functioning heart. So genetic causes of a dilated cardiomyopathy. There are metabolic causes of a dilated, poorly functioning heart. Glycogen storage disease, Pompei's disease, carnitine deficiencies, mitochondrial diseases, hypothyroidism. There are nutritional causes of a poorly functioning heart, thiamine, beriberi deficiency, and starvation. And certain drugs, I think you're all familiar with the anthracyclines treatment that we've used to treat many children with malignancies, can cause, at higher doses, a dilated, poorly functioning heart. So those are the causes of dilated cardiomyopathy, in addition to the viral myocarditis, which can also present with a dilated, poorly functioning heart. Okay, case presentation. Look at that x-ray. Look at that x-ray. Doesn't it look like somebody took a balloon, filled it with water, and put it on a table? Doesn't that look like it? Because that's what it is, folks, okay? Let me tell you about this. This is a 4-year-old presents with fever, chest pain, shortness of breath, acquired heart disease. On exam, heart rate 120, respiratory rate 60, JVD, jugular venous distension, increases with inspiration. This heart cannot fill. This heart is not filling well. The blood pressure is 100/66, but it goes down to 80/66 with inspiration, so-called pulsus paradoxus. Muffled heart tones, rales, hepatomegaly, and edema. And this is a echocardiogram. Here's the heart, left ventricle, left atrium, and there's a big pericardial effusion. This is a case of pericarditis with pericardial effusion. And there is this water surrounding of the heart, and it looks like a bag of water sitting on the diaphragm. The x-ray is absolutely typical. So what are the causes of pericarditis and a pericardial effusion in the pediatric patient? Bacterial pericarditis, yes. Strep pneumonia, H. flu, tuberculosis. Far more common are viral causes, Coxsackie-B, adenovirus, Epstein's-Barr virus, influenza. Collagen vascular diseases can present with pericarditis and a pericardial effusion. There is something called post-pericardiotomy syndrome. After kids go to surgery and have their pericardium opened, there can be an autoimmune reaction to that and concurrent viral infections that can cause pericarditis and pericardial effusion. Kids who have undergone mediastinal radiation can have pericarditis, post-traumatic pericarditis. Cancer, neoplasms can present with a pericardial effusion and pericarditis. And of course, uremia can present with pericarditis. What are the symptoms and signs to look for? Chest pain, respiratory distress, a pericardial friction rub can be heard. It sounds like when you rub your hair together near your ear, a scratchy kind of sound, and there's usually 3 components to a full-blown pericardial friction rub: ventricular relaxation, ventricular contraction, ventricular relaxation, and atrial contraction. Poor perfusion, pulsus paradoxicus, an exaggerated fall in the systolic blood pressure with inspiration. When you breathe in, your systolic pressure falls about 6 or 8 millimeters of mercury. I've seen people with big pericardial effusions, their systolic pressure goes to 0 when they take a breath in. Jugular venous distension. The heart can't fill, and this distension increases with inspiration, the so-called Kussmaul sign. All of these are signs of pericardial tamponade and need to be dealt with. So, treatment of pericardial effusion and pericarditis depends on the etiology. If there's tamponade, evacuate the fluid, just do it, okay? If you think the diagnosis, the etiology is viral, aspirin and bed rest are prescribed. If it's bacterial, you must drain the pus from the pericardial space and administer antibiotics. If the etiology is uremia, they need to be dialyzed. And if it's a collagen vascular or rheumatic etiology for the pericarditis and the pericardial effusion, steroids are administered. So it depends on the etiology. Acquired heart disease. Okay? Don't forget, patient presenting in heart failure after the infant period, about 10 years of age. It's not a left or right shunt. It's something acquired. Okay? Finishing up, I'm going to talk about a few common office-based cardiology issues. This is the stuff that you see in the office first. Chest pain in children. Okay, everybody look at this together. Look at the etiology. Musculoskeletal, pulmonary, GI. Look where cardiac is. On the bottom. So how come you send all of them to me? Okay, okay. Look at this, okay? So cardiac chest pain, of course, occurs, but it's not the most common cause of chest pain in children, and for sure not in the ambulatory setting. Okay? So, but let's talk about this a little bit because it's important. Chest pain in children is common, and intermittent chest wall pain in the otherwise healthy appearing child is almost always, are you ready? Benign. Totally. Okay? And laboratory testing should be limited and guided by the history and physical findings. So a chest x-ray for fever, cough, and chest pain. Okay? But otherwise, extensive laboratory testing will prove expensive and not helpful. Chest pain that occurs mostly at rest, I want you all to listen to this, sharp, intermittent, and pleuritic, called precordial catch syndrome, is extremely common and totally benign. No laboratory test necessary. So again, sharp chest pain, I've had it, 10 out of 10, right through the heart. Can't breathe, cannot take a breath in. Extremely common and totally benign. How many of you have had sharp stabbing chest pain as a kid? Raise your hand. Come on, let's see. There you go. Oh, wow, okay. 40%, okay? Completely benign. So it's a 10 out of 10 chest pain right through the heart. Yes, ma'am. And you can't breathe when you're having the chest pain. That's right. Goodbye, reassure. Okay? And by the way, there's an art to reassurance. Reassurance is, I promise you this is benign and nothing to worry about. What you don't do is go, this seems to be something benign, but if it keeps happening, come on back, okay? Now, here's another pearl, okay? This one you got to underline and everything. Chest pain or syncope that occurs only with exertion deserves a cardiology workup always. Okay? You still may not find anything, but it's more likely that you're going to uncover an underlying cardiac etiology. Are there cardiac causes of chest pain rarely? Yes, of course. But a history of chest pain with exertion, physical exam with murmurs and Marfan stigmata, acute ill-appearing child will lead you to the diagnosis. Outflow obstructions, you'll hear a murmur, mitral prolapse, myocarditis, the kid will look sick as a dog, pericarditis, arrhythmia, very sudden onset, very sudden offset. So they're not common, but they're out there. The ones that I remember that come to mind were a child with a myocardial abscess in the emergency room like this. You knew something was wrong. And another kid with a prosthetic mitral valve that had started to break loose and was painful and interfering with coronary flow. It's not hard to pick out the cardiac cases, okay? So for the most part, intermittent sharp chest pain in kids, benign. Okay, here's another one. Syncope in children. I don't know how this became to be a cardiac problem, okay? To me, it sounds neuro, but okay. 18% of the population will faint at least once. It's common. Okay, let's do it. How many people here fainted at least once? It's the same guys with the chest pain. What's with you? No, it's a different group. It's a different group. Okay. I did it once on a New York City subway train. Yeah. Oh, they came right to my aid, those New Yorkers. Something wrong with him. Okay. Okay. The most common etiology of syncope in children, it says 80% here, I'm going to say 90%. Neurocardiogenic vasovagal syncope. Simple vasovagal syncope. Diagnosis by history is often all you need. The typical history is one of standing up or getting up in church or in school. I don't know what the deal with is in church, but that's where it happens a lot, okay? Feeling dizzy, sweaty, pale. You ask the patient, did your vision start to go away? They say yes, tunnel vision, and they go down. What is thought to be happening here is the person standing up, maybe a little dehydrated, okay? Venous pooling, causing a heart to be relatively empty and small, which then starts to beat vigorously, okay? Sympathetic component to this maybe. Signaling receptors from the wall of the heart up to the brain. The brain comes down and says, stop that. Bradycardia and hypotension. That's the presumed pathophysiology. There's evidence for and against some of those components, but that's the most common explanation of what happens with simple vasovagal syncope. Okay, the famous tilt test should not be needed for the routine diagnosis of simple vasovagal syncope, neurocardiogenic syncope. Its use in pediatrics is only for the assistance of the diagnosis when it's not clear from the history and physical. And I don't know how many of you have seen this, but it is fantastic. So you take the kid, strap him down to the table, okay? It's a very high-tech test. Then you tilt him up, okay? And you wait. Everybody's betting. There's like bets going on the sidelines, okay? And yeah, sinus rhythm, and then it doesn't happen immediately. So when the residents tell me they did orthostatics, I said, it's not the same thing as a tilt test. This can happen 30 minutes later, 40 minutes later, flat. Look at that. Flat line. So no heartbeat, no blood pressure, no respiration. Dead? I don't know, okay? So you don't call a code either. What's that all about? You don't call a code. All you do is put them back in the supine position and they wake up. Okay? So that's the famous tilt test. Very dramatic and a lot of fun, but shouldn't be necessary for the routine diagnosis of vasovagal syncope. How do you treat this? Often, simply increasing fluid intake, something with some electrolytes in it is sufficient to, volume repletion is helpful, okay, in avoiding recurrent attacks of vasovagal syncope. Pharmacologic therapy, if necessary, so mineral corticoids to make you hold on to salt and water, such as fludrocortisone, can be helpful. Beta blockers used to be given, but they're really falling out of favor. They're really not recommended anymore. And in some cases, something to help combat the hypotension, so an alpha agonist to vasoconstrict the peripheral circulation, such as midodrine, is quite effective, okay? So treatment of vasovagal syncope. Now, again, a child with recurrent unexplained syncope, a child with syncope associated with exercise, could be a cardiac issue. Please get an EKG. Okay? We're looking for arrhythmic substrates like Wolff-Parkinson-White syndrome, long QT syndrome, hypertrophic cardiomyopathy. EKG is your best bet when you're trying to work up somebody with recurrent syncope. I mean, you don't need all these reams of paper of glucose tolerance tests, and just EKG is your best shot. Are there cardiac etiologies? Yes, of course. They're not common, and again, history and physical exam would steer you to these diagnoses. Left ventricular outflow obstruction, severe aortic stenosis can cause syncope, but there should be a big murmur that you would hear. Arrhythmias, your EKG will show you, most likely, either a long QT or Wolff-Parkinson-White or something, will give you a good clue. Cardiomyopathy, myocarditis, history, and physical would guide you to these correct cardiac diagnoses. But by far and away, simple neurocardiogenic vasovagal syncope is the most common cause of syncope in children. There are some non-cardiac associations with syncope that we know about. Obviously, seizures can cause syncopal-like episodes. I guess hypoglycemia can as well, okay? Legitimate. There's an interesting association of migraine in the history of children and families with vasovagal syncope. There's a little higher incidence of migraine-type phenomenon in children with neurocardiogenic syncope. Psychogenic, we've seen kids who are clearly faking it, okay, clearly. And kind of a close cousin of syncope is breath-holding spell, okay? Typically, this is a toddler, gets angry about something, cries, and then holds his breath till he turns blue, passes out, and has a seizure. And you tell the parent, this is benign. Good luck with that, okay? Okay, serious stuff. I want to talk about cardiovascular pre-participation sports screening. And now what we're talking about is the child who experiences sudden death as a high school or college athlete. So I want to share with you what are the causes of sudden cardiac death in the child athlete, and how should the pediatrician evaluate the child when asked to please sign this permission slip, which is probably starting about right now in the offices, okay? Okay, audience response question number 9. The most common cause of sudden unexpected death in the high school, child, college athlete: long QT, Marfan syndrome, hypertrophic cardiomyopathy, anomalous origin of the coronary arteries, aortic stenosis. Do it. Lots of clicks. Yep, I like it. So 90% of you chose hypertrophic cardiomyopathy, which is the correct response. The others chose other entities that are actually on the list of being important players of sudden cardiac death in the child athlete, but I want you to go home with the information that by far and away, hypertrophic cardiomyopathy is the big player. Okay? So sudden cardiac death in the child athlete is rare. but when it occurs, it obviously shakes up a community. And it's probably not as rare as we used to think it is. Okay? It's now that there are registries and more regular reporting, it's becoming more widely recognized. Here are the causes of sudden cardiac death in the child athlete. As we just demonstrated or talked about, hypertrophic cardiomyopathy is by far and away number one. Okay. The second most common cause, believe it or not, coronary artery anomalies. I'll show you a picture of those in a moment. Followed by, this is an entity that's now becoming recognized as possibly number two cause of sudden cardiac death in the pediatric patient athlete. This is commotio cordis. Have any of you heard of this? Okay. This is a child who's playing usually baseball or hockey or some other sport, gets a blow to the chest during a critical period of the T wave and goes right into ventricular fibrillation. Okay? So this also used to be thought to be rare, and now it's more commonly being identified and now is tied with coronary artery anomalies as the number two cause of sudden cardiac death in the pediatric patient. Number three, Marfan syndrome with aortic rupture. Number four, way down below there, 4% is all the other stuff that you usually think of, like aortic stenosis, long QT, other arrhythmia problems, okay, mitral prolapse, myocarditis, way down on the list. So hypertrophic cardiomyopathy, coronary artery anomalies, commotio cordis, aortic rupture. Those are your big players. Sudden cardiac death in the child athlete. Now I think, the next slide I believe, I'm going to show you a case of commotio cordis actually happening. I'm not doing this to shock you or to wake you up, well maybe a little bit, okay? But I want you to ask yourself, if you actually were there and saw this happen, would you know what had happened and what to do? Okay, so sometimes this works. Oh, it always works. Okay. This is a karate match. Watch the kid on the left. He's going to get hit in the chest. There's the kick. Okay? And he goes down. He's in ventricular fibrillation now. And this is commotio cordis. And it has a high mortality because what don't you see happening? No CPR. Okay? So early on, when this was not really understood, nobody knew what this was or what to do about it. But this kid received a blow to the chest during a critical period of time of cardiac repolarization, and this is now known to be the second most common cause of sudden cardiac death in the child athlete. Here, watch the hit again. There it is, right to the chest. Vulnerable period of the T wave. Okay. Okay, so keep in mind. Now, so how do you prevent death from commotio cordis? Urgent active defibrillation at the time of the event. Okay, so you have to recognize the diagnosis and do the right thing. Here's the other three common causes of sudden cardiac death in the child athlete. This is hypertrophic cardiomyopathy. This is the number one cause. Very thick interventricular septum, left ventricle, left atrium. These children suffer from arrhythmic death. Okay? This is what I'm talking about when I say anomalies of the coronary artery causing sudden cardiac death. Here's a normal aorta with a normal right coronary and a normal left coronary. The kids we're talking about have this arrangement. One coronary coming off the aorta, branching into a right and left coronary artery. And the problem is this segment right here, right between the pulmonary artery and the aorta, when the kid's exercising and the cardiac output increases and these vessels distend, this can squish the coronary artery that's bridging between them, cause ischemia and sudden cardiac death. And finally, this is another big player, and as I showed you on that list, Marfan syndrome with a dilated aortic root, aortic dissection as a cause of sudden cardiac death in the child athlete. By the way, Marfan syndrome is not the only cardiac condition that is associated with aortic aneurysms and rupture. So other entities include simple bicuspid aortic valve with aortic dilatation. They can rupture. And Turner syndrome. And I don't know if some of you were aware there was a big clinical trial looking at preventing aortic dilatation and Marfan syndrome, looking at losartan versus beta blockers, and there was really no difference between the two, although there was a lot of excitement initially that losartan would be far, far superior. Okay, back to this problem. What do we do about this problem of sudden cardiac death in the child athlete? Well, routine, what you would think might make sense but doesn't seem to, routine electrocardiographic and echo screening of all athletes currently not recommended in the United States. Rather, the American Heart Association and the American Academy of Pediatrics have endorsed a strategy of screening children through targeted history and very focused physical exams to identify at-risk kids. So the recommendations are along the lines of screening all athletes before participation in high school and college sports. And for high school students, repeat screening every 2 years. History, ask a history of exertional syncope, near syncope, chest pain. Family history, any premature death or disability from heart disease in relatives less than 50. Ever hear of the word Marfan syndrome? Ever hear of the word long QT? Ever hear of the word hypertrophic cardiomyopathy? Physical exam, looking for stigmata of Marfan syndrome, looking for coarctations, blood pressure, and heart murmurs. If the screen is positive, refer to a pediatric cardiologist for evaluation. And just so you're aware, there are reports in the literature, most notably out of Italy, saying that they did do cardiovascular EKG screening on all athletes, and they did reduce the incidence of sudden cardiac death from hypertrophic cardiomyopathy significantly. But there have been arguments back and forth about the validity of those statements, just so you know. And there are proponents in the United States of doing EKG screening on child athletes. Okay, finally, prevention of adult heart disease. Lipid, cholesterol screening in children. Talk about that. But first, have you heard changes in the adult world? These are really cool. All your life, you were told, don't eat eggs, cholesterol is horrible, you're going to die, okay? That's all. We were only kidding, okay? So cholesterol is no longer considered a nutrient of concern. U.S. Dietary Advisory Committee, December 2014. Don't worry about your cholesterol, about eating cholesterol. And in the adults, when they're treating elevated lipid levels, they don't follow LDL levels anymore. They're not supposed to do that. All you're supposed to do is calculate somebody's 10-year risk for developing coronary heart disease, and based on that calculation, you either give them a low, medium, or high-intensity dose of statin drugs, and you're done. Okay? So those are the kind of cool, interesting changes in the adult world. Hasn't filtered down to pediatrics yet. Let me show you what we do in pediatrics. Okay, so here you go. Adult response number 10, audience response. In order to identify children who are at risk for atherosclerotic heart disease as an adult, measurement of serum cholesterol or lipid screening is now recommended for A, only children with medically treated hypertension, B, only children with a parent with either a total cholesterol greater than 240 or a close relative with coronary artery disease, 65 years or less in females, C, only children with type 1 diabetes, D, only children with obesity and a history of tobacco use, E, all children between 2 and 11 years of age. Start your clicking. Okay, interesting. Okay. So the majority got the correct answer, which is in today's world, now we are recommending screening for dyslipidemias in all children sometime between 2 and 11 years of age, and I'll break that down for you in a minute. The folks who answered B, that used to be correct. That used to be the older targeted recommendations, okay? But kind of done away with that, and now everybody gets screened during childhood. Okay, so as I'm pointing out on this slide, screening everybody is now the newest guideline and what is now recommended. We used to do the targeted screening based on factors such as your parents, history, et cetera, but newest guidelines recommend screening all children for elevated cholesterol and LDL. Okay, so here's the guideline. We recommend universal screening, measurement of cholesterol and or fasting lipid profile, depending on, it's indicated on the slide here. All children between the ages of 9 and 11 years of age. Those children who you think are high risk because of a family history or other issues like diabetes, et cetera, should be screened between 2 and 8 years of age. And that should be a fasting lipid profile. And then again, universal screening of all children again at 17 to 21 years of age. So this is a very different kind of recommendation than a few years back. Okay? So just be aware, the newest recommendation, everybody gets screened. Okay. For patients who are overweight or obese with high triglyceride levels or low levels of HDL, the good cholesterol, treatment is weight management, nutritional counseling, increased physical activity. For patients who are over 8 years of age with an LDL greater than 190, that's the bad cholesterol, or other risk factors and even lower LDL level targets, we recommend a trial of diet and lifestyle changes for about 6 months, and then if necessary, drug therapy. And increasingly, we are turning to statins as our drug of choice, even in the pediatric patient, to achieve desirable LDL, the bad cholesterol, levels. While on the subject of cardiovascular health, there's a new clinical practice guideline on the management of hypertension in adolescents and children. And there are new normal values now because we all know that normal blood pressure values are based on what? Age, gender, and height. The old norm values had all children included. The new normal values have excluded anybody who is not of normal weight. So more children have risen up into the pre-hypertensive and hypertensive category. Okay? And this is a very long, detailed, wonderful publication, but to summarize it in 2 sentences, lifestyle modifications, regular exercise, DASH diet, that's a dietary approach to stopping hypertension. Low sodium, high potassium, good nutritional diet. If no improvement, pharmacologic therapy. So kind of like the cholesterol story, a trial of lifestyle modification. If no improvement, you're on drugs. That's a little new for pediatrics. Okay, a couple of high-yield pearls, and then we're done. Okay, supraventricular tachycardia is the most common tachyarrhythmia in the pediatric patient. Remember, if they're unstable cardioversion, IV adenosine, drug of choice. Left to right shunts, VSD, ASD, PDA cause symptoms at 4 to 6 weeks of age. Long-term complications include this, right? Irreversible pulmonary hypertension. PGE1, prostaglandin, for the palliation of cyanotic congenital heart disease and critical left heart obstruction in the newborn. Remember, the critical coarctation, the hypoplastic left heart syndrome. Aortic stenosis, often progressive. Pulmonic stenosis, not progressive after 2 years of age. Remember the association of aortic insufficiency and dissection in Marfan syndrome. Kawasaki's disease and IVIG, you all knew that. Rheumatic fever, know the Jones criteria. Know that hypertrophic cardiomyopathy is the leading cause of sudden cardiac death in the child athlete. And remember that all children should undergo cholesterol lipid screening before 11 years of age. Thank you for your attention. Good luck to you. Bye-bye.